We are live.
A very warm welcome to one and all of you to our ARC PG Update webinar. Would I say that this time we've come with a difference? And as the webinar proceeds, what is going to come to fore is how the art of thinking would open up that right path in our maze of thoughts, open up those crevices in that hunt for the answer, pick up those sharp clues which are actually lying within, sharpen our intellect to diagnose the disease better, and appreciate its ramifications in totality. I'm so sure that you would inculcate this art of thinking and learn better after today's webinar. Our expert panel is one strong army today. We have with us Dr. Lalit Varma, who has held major honoris posts at AIOS as the Honorary Secretary and Chairman Scientific Committee, and has brought in huge changes in the strength of the society. After a major stint of 14 years as the Senior Vitreoretina Consultant at RP Center, he became the backbone for the posterior segment at CFS Group of Hospitals based in New Delhi. He has over 172 publications, has been honored with a huge list of awards and accolades in his remarkable career. Dr. Raj Narayan, who's to join us shortly, is our next expert panel, has had an extensive educative career in premier institutions world over, and currently also the Adjunct Associate Professor of Ophthalmology at the University of Rochester, New York. He's the Director and Network Head, Clinical Research at LB Prasad Eye Institute, Head Operations and Systems, Kala Manji Reddy Campus, and Kode Venkatadri Chowdhury Campus, and a consultant vitreoretina diseases at Srimati Kannuri Santama Center. He has published widely in top reviewed journals, contributed to books, and received some most exemplary awards. Dr. Anand Rajendran, who's our next expert panel, is the Chief of Vitreoretina Services at Irvine Eye Care Systems based in Chennai, has a huge list of published research papers in peer-reviewed international and state journals, and he's also the convener scientific committee of the Vitreoretina Society of India. Dr. Mona Bende is the Deputy Director of Sri Bhagwan Mahavir Vitreoretina Services at the Medical Research Foundation at Chennai, extremely prolific and a very knowledgeable woman, internationally renowned ophthalmologist with a phenomenal contributions in peer-reviewed journals and awards and accolades which truly follow a personality of her caliber. Dr. Srinivas Joshi, leading the Vitreoretina and Uvea department at MM Joshi Eye Institute, Hubli, is a fiery energy to reckon with amongst the young ophthalmologists. Besides being an amazingly skilled surgeon with a very impressive academic career, his area of interest has been artificial retina, one of the first Indian to be trained in this complex field with some of the most impressive awards received at a young age, reflecting his brilliance. He is also the member ARC South with a brilliant future ahead. Dr. Ashray Naika is another of a young dynamic team in this expert panel, a senior consultant at the Vitreoretina department at Coimbatore branch of the Eye Foundation Group of Eye Hospitals. He has a brilliant and innovative style of his own, who additionally qualified himself as a lawyer and would continue to challenge himself to perform his ultimate best and be the pride for the ophthalmic community at large. Dr. Avinash Patanjay, whose brainchild is this webinar, would be moderating this awe-inspiring session with me. After a very vibrant educative career, Dr. Avinash joined the LVPI groups in 2001 and is presently the Director of GMRV campus at LVPI Network, Director of Eye Care Education, Consultant Vitreoretina and Uvea with more than 103 peer-reviewed publications, presentations in huge numbers, video awards and accolades. An individual who believes how tutoring and harnessing the human mind is the key to nourish the acumen of clinician skills. When you watch this whole webinar, you will be amazed at the dedication of this teacher, Dr. Avinash Patanjay, and the genius of his very capable young team to put forth everything so simplistically. And before we go on to the crux of the main webinar, let's hear from Dr. Avinash himself, the man behind the scenes, who has left no stones unturned to deliver the best to our very dear attendees today. On to you, Dr. Avinash.
Thank you so much, Dr. Chitra Ramurthy, for this extreme kind words. At the outset, I would like also to thank the panel members and a sort of an inspiration. And this inspiration, right, comes from my teachers with whom I had had my fellowship. And one of the teachers, Dr. Mona Bende, is still here. as panel members. So before I go on to make people understand about the art of thinking, so let me impress on the statement which is very important for medical profession, that learning is a lifelong process. When trainees come into an organization, they usually feel that, let me learn the skill, let me learn the surgery, and let me learn the diagnostics, how I'm supposed to interpret, let me know how to do an injection. But believe me, with the rapid advances and strides made today, most of them would get outdated in the next 5 to 10 years. But we have to understand that we have a professional career of nearly 40 to 50 years ahead of us after a training period. And that's the reason why I said learning is a lifelong process, more relevant in medical profession. And if we have to understand this and abide by it, certain fundamental skills are very important. It is like the app, what we have heard, it's like if you have to help someone, the best way to help someone, a person who's really hungry, is to teach them how to fish than giving them a fish. Now, if I have to talk about more about it, so we have identified many skills which would help to enroll that learning is a lifelong process. And three of the most important aspects are in conjunction with the medical profession is observational skills, curiosity skills, and thinking skills. And this evening, we are here to promote the thinking skills, a very important part of this entire process to make an normal physician into an astute clinician, and that's what we have to be. Thank you again, Dr. Chitra Ramurthy, for having immense trust on us and giving us an opportunity to present.
Thank you, Dr. Avinash. So we have three young, bright, very charming speakers, the young faculty of Visakhapatnam Center at LVPI. The first is Dr. Anamika Patel to go on. A very bright young mind, has graduated from Bharati Vidyapeeth Medical College and after a residency in ophthalmology from Mahatma Gandhi Mission Institute of Health Sciences, she moved forward and completed a fellowship in medical retina and UVI at LVPI and is currently practicing at GMR Varalakshmi Campus, Visakhapatnam. We shall start off with Dr. Anamika, who is going to be regaling us on the history of thinking and types of thinking, concrete and abstract thinking. On to you, Dr. Anamika.
Thank you, Dr. Ramamurthy, for the kind intro. I'll just share my slides. So on the behalf of my team and on behalf of the LVPI, Dr. Chitra Ramamurthy, it's again a huge heartfelt thank you for giving us the opportunity to come, speak, and teach. So Albert Einstein, we all know him. He once said that the world as we have created, it's a process of our thinking. It cannot be changed without changing our thinking. And I must say, what a profound statement. So today, this evening, for the next 3 hours or so, we are going to witness the same. So today I'll be speaking on the history of the critical thinking, and following that, I'll take you to the various types of thinking and the clinical and the application in the practice. So my talk, I have divided into the Western and the narrative and the Indian narrative. Indian narrative being my personal favorite. So let's take a look for the Western narrative. So about 2,500 years ago, there lived a man known as Socrates. He is still considered the father of the critical thinking. He was of the belief that I cannot teach anybody anything. I can just make them think. And now just for a moment, let's just reflect on this very profound thought that we cannot teach anybody anything. We can only make them think. And I wish and I hope that we all are able to do that. And Socrates was the one who developed the Socratic questioning. And if you ask me, Socratic questioning is just about adding this beautiful word why in front of any statement that is given to you. It's like somebody asks you something and you give a statement and then he says why. You give a reason and again, the person doesn't stop there and ask you, but why? And then again, you give a reasoning and the person asks you, okay, but why? So it is all about asking the questions which gives you a clarity and gives your thought process a logical consistency. Now let's leap into the Middle Ages, where Thomas Aquinas, now he was an Italian domination, a very influential philosopher, theologian, and a jurist of his time. And he himself believed that those people who think critically, they do not always reject the established beliefs. Rather, they reject only those beliefs that lacks the reasonable foundations. Coming to the beautiful Renaissance period, from the France, we had the Francis Bacon, who was very concerned with the way the people use their mind, rather misuse their minds in seeking knowledge. The very first book which came in the critical thinking was from him, which he wrote upon the advancement of learning, and he said that critical thinking faculty is extremely important, and he really put a lot of importance in studying the word empirically. He in fact laid the foundation for the modern science with his emphasis on the information gathering process. And then 50 years later, René Descartes, now he's one of the most sought after minds when it comes to the critical thinking. He wrote this book, Rules for the Direction of the Mind. Now, this is considered the second text so far in the critical thinking if you look into the history. And he developed and introduced to the world the stepwise approach to the critical thinking. He was of the belief that every part of thinking, it should be questioned, it should be doubted, and it should be tested. The same thing what we see in today as well. It's all about that what we speak about the evidence-based practice. It is that one person says something, you do not stop at it. Now just reflect on the Socratic questioning itself. This is of the same similar thought that is happening. And then in the 18th century, as the critical thinking and its reasoning, everything was developing, two very important texts came into the world, and one was related to the economics by Professor Adam Smith, who wrote on the wealth of nations, and the another one on the reasoning. It was by the Immanuel Kant, who actually wrote the Critique of the Pure Reason, is considered still one of the very important texts in the art sciences. And then in the 20th century, William Graham Sumner, he wrote this very important book. It was actually a pathbreaker of those times, where he wrote Folkways, which was a study of the sociological importance of the usage, manners, custom, etc. He was a professor at Yale University, and he wanted his colleagues and his students to have a very important faculty, which is the critical faculty. He felt, and he has written in his books, that school education, they kind of make people orthodoxy. The men and women, when they are taught only one pattern, they turn into a lath. The idea is to keep questioning and to keep reasoning. And then in the modern world, John Dewey, who was a successor, he was also on the similar lines. He felt that the reflection is very important. So far, in the last few minutes, I have asked all of you to reflect on the statements. So it's all about learning from the experience. We learn from reflect when we reflect on the experience. So with this, I finish my narrative on the Western, and let me take you all to the beautiful Indian narrative, which is led by just one person, which is Chanakya. Now, Chanakya, as you all know, that he was a teacher, philosopher, and a strategist in the 4th century before Christ, and he has written Arthashastra. Now, Arthashastra, before I come to the Arthashastra, he is also known as the official kingmaker of India. Now, Arthashastra has a lot of things under it. Like, if you just look at this photograph here, it depicts so many subtopics, be it law, be it theories on war, be it nature of peace, diplomacy, etc. So, back in those days in India, in the ancient India, all the kings, all the rulers, they used to send their kids, basically the princes, so that they can go and would be honed under Chanakya, so that they could learn this Arthashastra, how to go about managing their states. But Chanakya was of the belief that before a student learns anything, it is extremely important that a student's ability of thinking logically should be developed first and foremost. I was really wowed by this statement when I read for the very first time. And Chanakya, he developed a subject which is known as Anvikshiki. Now, Anvikshiki is a Sanskrit term. It is basically made up of two words, Anu and Ikshiki. So, Anu means atom, it is the smallest part of anything. And Ikshiki means an inquisitive person, a person who wants to know, is an inquirer, a thinker, or a researcher, an examiner, or logician, anything, however you want to put it. So, his student learns Anvikshiki before they actually learn the Arthashastra. Such lucky students. So, back in those days, those in fourth before Christ time, Chanakya developed 6 types of thinking: both side, alternate, leadership, creative, lateral, spiritual. There are many more to it, and I'm not going to go into the details of it. But just think about it, how profound it has been. So I've given you the narrative, the Western and the Indian narrative of the thinking. And let me take you to the second objective of my today's presentation, which is type of thinking. Now, today, me and my colleagues, we are going to take you all through the 6 types of thinking which are there in this modern world: concrete, abstract, analytical, divergent, convergent, and creative. So, let me take you all to the first 2 types of thinking, that is concrete and abstract. So, concrete as a word in itself, it means a very basic thing. It's your perception. It's your perception in its very simple form. That whatever you can perceive through your 5 senses, be it your smell, sight, sound, taste, or touch. So, when I show you a photograph like this, where you see the retina which is lifted up, the only thing that comes to the mind is, oh my God, I'm seeing a retinal detachment. So, when you just think about that I'm just seeing a retinal detachment without really putting anything to the right or left of that statement, that is concrete thinking. Another example, you are looking at this left eye fundus photograph of a person who had a presentation like this. Now, when you see something like this, where you see there is some subretinal hemorrhage, you are seeing some yellowish thing, the first thing that comes to mind is that I'm looking at a choroidal neovascular membrane. When you just blurt out, when you just say the first thing that comes to your mind, that is the concrete thinking. Let me give you another example. A patient comes to you and he says that I got operated for the cataract surgery and I can't see, and has a photograph like this. Now, the first thing that comes to your mind is that this patient is end off. You're not really going into the details of it, but you're just looking at it, and you're acting on the first thought. So I've, over the last 30-40 seconds, I have given you a kind of an understanding of what a concrete thinking is. It's again is based on your senses, the very first thought that comes into your mind. Now let me take you to the another type of thinking, which is known as an abstract thinking. Now, as the word abstract, as we understand, it's about reflecting on any past experience of yours, or when you start kind of comparing what you're looking at, it's actually kind of centered around the reflection of your past or on any experience. So we all have done our residency, and few are still doing that. And all of us know that the central retinal vein occlusion photograph is written in the textbook that it has that tomato splash appearance. Now, why does that word, from where is that word coming from, tomato splash appearance? It is because it looks like that somebody has splashed the tomato and everything is so bright and, scattered everywhere. And this is how the CRVO looks like. So we are reflecting on a particular pattern of a splashed tomato. So that's the reason why we have that. Let me give you another example. Now, in endophthalmitis, sometimes in candida endogenous endophthalmitis, we get to see a rain cloud appearance. So, if the word rain cloud comes, so from where is it coming? It's just because on somebody's abstract thinking that they felt that it looked similar to a rain cloud. Let me give you another example. When you see retinal detachment with the presence of this HST. Now, the reason why it is called HST, because it reminds us, it's particularly actually it reflects on our thinking that it is similar to the horseshoe. Another example we can see is, in suppose if you see a low grade endophthalmitis and you look at a plaque and you think of a plaque, so you are actually reflecting on the pattern. So over last few minutes, I have given you a narrative on the history of the thinking. So look at so many people, they were all there and they have evolved and they have come closer to what we understand what critical thinking is. This all happened in the West. And in our country, in our own ancient India, there was just this one guy, Chanakya, who surpassed everyone and developed the subject known as Anvikshiki, which is so important before we learn anything. And let me just take you all back to what we have reflected, as John Dewey once said, that concrete thinking is all about coming to just one particular thought process when you are just looking at it and you just blurt out. Like when you see an RD, you just say it is RD without actually classifying it. When you see a membrane, you just call it a CNVM or you call it just ENDOPH. And abstract thinking is when you actually reflect on any particular idea or any particular experience of yours or any imagination that you have. For example, splash tomato for CRVO or rain cloud for this particular OCD sign. So before I ask Megha to take you to the next type of thinking, I leave you this one question. How many times in your life you all have made a diagnosis based on your abstract and concrete thinking? Over to you, Megha. Thank you.
Can you stop sharing? I think I owe to Megha to introduce her. Our next bright star is Dr. Megha, who after a primary medical education at RCSM Government Medical College, Kolhapur, followed up with her post-graduation in Patna Medical College and pursued a fellowship in vitreoretina and uvea at LVPI, Visakhapatnam, and continued as a young faculty herein. Dr. Megha Gulati would help us understand things with a better perspective, delving into analytical and divergent thinking. On to you, Dr. Megha.
Thank you, Dr. Chitra, for such kind words and for giving me an opportunity to be a part of this conference of types of thinking. So today I will be taking you through another two types of thinking, that is analytical and divergent thinking. But before I do that, I would like to thank Anamika for explaining us the concrete and the abstract thinking. And to just reiterate before I start with my main topic. Now, the concrete thinking is based upon physical facts and literal meaning without using concepts and generalizations. While abstract thinking, it is symbolic thinking. That is when you are trying to gather the information with all your senses and trying to make stronger connection. Like if you see the Statue of Liberty and someone tells you what it is, you just use a concrete thinking and say it's Statue of Liberty. But someone who has a good abstract thinking, observation skills and all, it will say that it signifies freedom and justice. So this is what the difference between the concrete and the abstract thinking. So myself, Megha Gulati, I will be taking you through next two types of thinking. And to start with, I will be discussing the analytical thinking. Now, before taking you through the clinical scenarios, so Anamika has used the example of choroidal neovascularization, retinal detachment, and endophthalmitis to help you understand the first two types of thinking. I and Prabjor will also be using all these three examples to continue with the next four types of thinking. But before I start with the clinical scenario proper, just to give you a glimpse of what analytical thinking is, now in a day-to-day clinical situation, I go to market and I wanted to buy a new dress. Now, whether I should buy this dress or not, how should I decide it? What do? I try to judge it based on its color, its material, whether it's stitched, unstitched, what is the size, brand, cost, discount, and all these things. And then I come to a conclusion whether I want to buy it or not. So the decision to buy it or not was made easy when I tried to judge this decision based on the key information which is available in this form. So this is what is analytical thinking. It is a step-by-step methodical approach where you try to solve a complex problem. So you have a complex problem. To divide the information, you take out the key information from the data, and then you try to analyze that key information. So breaking down the available information into parts and then coming to a conclusion. So why are we doing that? Now the complex problem can be solved quickly and effectively by doing this analytical thinking. Now let me take you through clinical scenarios to understand this. Now this image Anamika has also showed you, and then she told that using concrete thinking, it is a choroidal neovascularization. She was very right in saying that. There was no wrong in that. But let's see into detail what this fundus photo shows you. So there is this obvious subretinal grayish yellow membrane present at the macula, especially at the nasal macula involving the fovea. Then there is this subretinal hemorrhage. Now there is something more into it. Now if you see that there is this gray fine irregular line which is emanating from the disc, which is more prominently visible on this autofluorescence picture. Now, this image has three important information. So we are trying to break down this fundus photo into three important points. So it has a subretinal grayish yellow membrane, it has subretinal hemorrhage, and there is this gray fine irregular line. Now, what does it point to? It is that it is a choroidal neovascularization secondary to angioid streak, right? Coming to the next case scenario. Oh my God. So seeing this fundus photo, you might get scared that what the diagnosis is. It looks so complex, but let's try to solve it very easily and effectively. Now, what is the most prominent finding that you can see in this fundus photo? It's this retinal detachment. Now let's analyze the retinal detachment itself. It has convex borders with smooth surface and it is seen inferiorly. That is, it is in dependent position. And I assume that there are no breaks. So most likely this retinal detachment is an exudative retinal detachment. So this was the prominent finding of this fundus picture. Now what is this? This whitish lesion, what you can see superior to the disc and here also. So this is that subretinal fibrin, but it has a characteristic feature in that. Now in this fibrin, you can see that there is central clearing which is there, right? And if you grossly look at the fundus photo, there is reduced tessellations. The background has reduced tessellations. So now this point points towards that this fundus has a pachychoroid. Now, what is the important information which this fundus photo gives you? That it has the exudative retinal detachment. There is this subretinal fibrin, which has a characteristic central clearing, and then we have a pachychoroid. Now, it becomes easy to come to a diagnosis. The subretinal fibrin with central clearing and pachychoroid points toward central serous chorioretinopathy. And when there is this exudative retinal detachment, that means we are dealing with a case of bullous central serous chorioretinopathy. So this complex problem became so easy in just seconds when we divided the information into different parts, right? Now, another example of endophthalmitis. Now, this image was shown by Anamika also, and then she also concluded that this is endophthalmitis by her concrete thought, right? Now, let's try to analyze it and try to gather the key information from this image. Now, there is conjunctival congestion and chemosis, which is there. Then we can see this temporal conjunctival incision pointing towards that a temporal SICS has been done in this patient. Now, the cataract surgery was done 1 week back in this patient. Now, here what we can see is that there is scleral infiltrate at the edges of the wound, which is there, as well as a corneal infiltrate at the wound can be seen, right? This hypopyon is present, and then we have a PCIOL and a fibrin membrane over it. And as the fundus was not visible, B scan shows low to medium amplitude dotted membrane is echoes in the anterior vitreous cavity with a normal retinochoroidal complex. Now, the diagnosis was well known that it's an acute postoperative endophthalmitis. But what does these three information point to? Now, patient has redness, pain, and blurring of vision since 7th postoperative day. Then we have a corneoscleral infiltrate, which is there. We have a hypopyon, and B scan is showing vitreous echoes. Now, it's an acute postoperative endophthalmitis, but with microbial keratitis, that is, there is a corneoscleral infiltrate. And seeing this clinical scenario, I can point out that most likely this endophthalmitis is caused by a high virulent organism. Now, why do I say so? Let me just give you two learning points with this clinical situation. When we suspect that endophthalmitis is caused by high virulent organism, whenever the onset of symptoms is within 2 days of surgery, when the initial vision at presentation is only perception of light, when there is loss of red reflex, when there is relative afferent pupillary defect present, or there is a corneal or cataract incision infiltrate as present in our case. Now, talking about this cataract incision infiltrate, how do we differentiate whether it is infective or immune mediated? Now, infective infiltrate will not have a clear space between limbus and the infiltrate. It will usually be full thickness of corneal involvement and they will respond to antibiotics. While on the other hand, the non-infective or the immune infiltrate, they will have this clear space between the limbus and the infiltrate. It will be mostly initially the stromal involvement and not the full thickness. And then this immune infiltrate will respond to corticosteroids rather than antibiotics. So these were two important points. So now with the help of these three examples, I think I would have been able to make you understand what is analytical thinking. That is, we break down the information, we try to extract the key information from the data and try to solve the complex problem effectively and quickly, right? Now coming to the next type of thinking, that is divergent thinking. Now divergent, as the name suggests, it means the same. But before I take you through the divergent thinking proper, now as I went to a market previously and I was analyzing a particular dress, now I want to decide which dress should I buy. What all can come into my mind? Now, these thoughts can vary from common dresses to uncommon dresses or to new creative dresses, right? So I can buy a salwar suit, a sari, skirt, dress, jeans, whatever I wish to. Now, whatever these thoughts come to my mind when I have a problem or I want to find a solution for a problem, all these options what come to my mind is what is called the divergent thinking. So this divergent thinking, it is very free flowing and continuous process. It involves creativity in it. So it's a free flowing, continuous and a creative process. When you have a possible, when you think of possible solutions and differential diagnosis to a problem. So this is also a step-by-step methodical approach, but here you try to have your creativity in it, and then you think of common, uncommon, and new ideas. So with the same three examples, you will understand what is divergent thinking. Now, if you tell me that the patient has choroidal neovascularization, I will not stop there. I will think of what will be the cause for this choroidal neovascularization, and innumerable causes will come to my mind. It can be a central serous chorioretinopathy. Why I say in this patient? Because the patient has gravitational tracts, these RP changes with the subretinal hemorrhage. Now, it can be a myopic CNVM when we have this markedly tessellated fundus with a tilted disc with a peripapillary chorioretinal atrophy and focal and diffuse retinal atrophic patches with this large subretinal hemorrhage. Then in this patient, I can see that there is a peripapillary white membrane with subretinal fibrosis and then pigmented scars in the mid-periphery. Most likely it is a multifocal choroiditis, so it's an inflammatory CNVM. Then in this aged patient who is presenting with these multiple drusen's and a membrane at the macula, there is no doubt that this is wet age-related macular degeneration. Now in this patient on OCT angio, when I can see a net and the patient is having this perifoveal grain, it can be parafoveal telangiectasia. Then last but not the least, this patient, we have already seen this patient in our analytical thinking. But what these lines which are emanating from the disc, they are much more larger compared to our previous photo. And then we can also see this beauty orange appearance in the temporal macula, these white comet tail bodies, and then the macular dystrophy which is there. So now this is CNVM secondary to angioid streaks. But because of these characteristic other features which are present, and using the analytical thinking, I can come to a conclusion that this CNVM in an angioid streak patient is most likely secondary to pseudoxanthoma elastica. So thinking of CNVM, I thought of innumerable causes, and then I tried to analyze each fundus photo. Coming to the other example, exudative retinopathy. I will think of unlimited causes of exudative retinopathy, starting with this case where I have a subretinal focal inferior to the disc yellowish lesion with surrounding retinal edema or neurosensory detachment which is there, and retinal hemorrhages with a characteristic T sign on B scan. This is exudative retinopathy secondary to nodular posterior scleritis. Then this, no doubt in that, it's a Vogt-Koyanagi-Harada syndrome. Why I say so? Because it has multiple neurosensory detachment, hyperemic disc with RP undulations and these septae on OCT, which is characteristic of BKH syndrome. The other cause of exudative retinopathy can be this rare cause where patient is giving me the history that she had breast cancer. She was treated with chemotherapy and radiotherapy for the same 3 years back. And now it's presenting with exudative retinopathy and this dome-shaped subretinal large lesion in the temporal macula extending till the mid-periphery. So this exudative retinopathy will most likely be due to choroidal metastasis. Then this clinical picture we have already seen in our analytical thinking, this exudative retinopathy with this multifocal leaks on angiogram and this RP rib. This is bullous central serous chorioretinopathy. Then this leopard spot appearance and exudative retinopathy makes me think of uveal effusion syndrome. Now this patient giving me the history that patient was lasered as in form of pan-retinal photocoagulation second setting 1 week back and is now having diminution of vision. This is exudative retinopathy, which might be most likely if the patient's systemic parameters are not under control or excessive power is used. So exudative retinopathy secondary to laser photocoagulation. So thinking of exudative retinopathy, we thought of multiple causes and then we tried to analyze each of them. Now, another example, as I told you, endophthalmitis will be our last example for divergent thinking. Now, if you tell me endophthalmitis, I will not stop there. I would like to know what is the type of endophthalmitis as it can be innumerable. So if there is this characteristic clinical picture in front of you with this ACIOL, which is popping out of this corneal incision, this is acute postoperative endophthalmitis. Now this PC plaque, what Anamika has shown you, is characteristic of delayed postoperative endophthalmitis. Now this patient having a corneal tear with the traumatic cataract and a hypopyon, most likely this hypopyon will be infective. I would like to do a B scan. So this is traumatic endophthalmitis. This patient was treated for traumatic endophthalmitis in form of intravitreal antibiotic injections and systemic antibiotics. The end of part resolved. But then this patient again presented with this hypopyon. Now this hypopyon is different from what the patient was having hypopyon prior. Now you can see that there are these refractile particles and you can see those crystals in it. I will label it as pseudoendophthalmitis. Now, why do I say so? A passing clinical pearl that pseudohypopyon has a ground glass appearance and these refractile particles can be seen. It has characteristic shifting position and you can see that the eye is quite compared to what it was previously. So patient was given intravitreal triamcinolone, which has come into the anterior chamber as the patient was partly aphakic. Now, we saw acute post-op endophthalmitis, delayed post-op endophthalmitis, traumatic endophthalmitis, pseudoendophthalmitis. Last but not the least, this patient presenting with a blood-tinged hypopyon with no history of trauma, no history of cataract surgery, and fundus examination shows me this pre-retinal exudates in the vitreous cavity, in the posterior and the mid-vitreous cavity. And then patient is giving history of having been operated for hernia 2 to 3 weeks back. Gives me a clue that this is endogenous endophthalmitis. So just thinking about endophthalmitis, I can think of innumerable causes or differential diagnosis. So exploring the many possible solutions or differential diagnosis to a problem or a challenging clinical case, which can vary from common to uncommon or new or creative ideas is what is divergent thinking. So with the help of 3 examples of choroidal neovascularization, exudative retinopathy, and endophthalmitis, I hope I made you understand what is analytical and divergent thinking. Now, once we have a problem with us and we think of various options which are there, this is what I told you is divergent thinking. Now, when I try to analyze each of the solution or differential diagnosis I have is what is analytical thinking. Now, after analyzing it and breaking down the key information into different parts, when I come to a conclusion, this is what is convergent thinking. So here I would like to request and hand over to Prabjor, my colleague, to take you all through convergent and creative thinking. Thank you all.
Can you stop sharing? So introducing a very nice talk, the first 2 talks, I'm sure it has given you a glimpse as what all is going to be discussed and with what great detail they're going to address it all. So introducing you, the third shining performer is Dr. Prabjor, who after completing her primary medical career at BJ Medical College, Pune, did her post-graduation at Shankar Dev Nethralaya and then pursued a fellowship in VR and UVR services at LVPI Bhubaneswar and then Visakhapatnam. Her keen interests are in retinal vascular disorders, surgical retina, and ROP, with a passionate interest in teaching, and works as an ophthalmic educator in the LVPI education team. And to keep you as enraptured, Dr. Prabjor Kaur, would you take you deeper into the concepts of convergent and creative thinking? On to you, Dr. Prabjor.
Thank you very much, Dr. Chitra, for that introduction. I will just share my screen. So once again, good evening, everyone. And I would like to thank Anamika and Megha for very nicely taking us through the history of thinking and then told us about everything that one should know about the 4 types of thinking, which was concrete thinking, abstract thinking, analytical thinking, and divergent thinking. Now, I will be taking you to the last 2 types of thinking, which is convergent thinking and creative thinking. So once again, I'm Prabjor Kaur, and let's begin with the first one, which I will be taking you today, that is convergent thinking. Now, as the name itself suggests, convergent thinking is nothing but putting different pieces of all the information that is available to you in a logical and an organized manner, and helps to come to a definitive diagnosis or a conclusion. Now, this term was coined by Joy Paul Guilford, who also coined the term divergent thinking. Now, convergent thinking, it generally means the ability to give the correct answer to standard questions, and it does not require significant creativity, unlike divergent thinking, which requires a lot of creativity involved, because as many possible solutions one can think of to a given problem involves some amount of creative process. Whereas convergent thinking, what needs is logical reasoning and thinking. Now, we have all been doing convergent thinking when we have entered and basically passed so many competitive examinations where we have been given multiple choice questions. So convergent thinking is nothing but type of thinking that focuses on coming up with the single well-established answer to a given problem. So with this short background, let me now take you through the cases. So starting with the first case is of a lady, 45-year-old, who presented to us with complaints of diminution of vision in the right eye. Very obvious, you can see these ILM folds radiating, right? Along with that, there was a very shallow neurosensory detachment, which was evident clinically. Now, you can see these osities of the right eye and left eye. The neurosensory detachment that was seen clinically was very beautifully picked up on OCT in the right eye, as well as there was a very shallow neurosensory detachment in the left eye. What you see here are these RPE undulations along with hyperreflective dots in the choroid. So what does FFA show now here? So FFA shows presence of these hyperfluorescent dots, which you can see in both the eyes, along with pooling of dye in the later phases and a very prominent hot disk that is seen here. The B scan showed presence of increased sclerochoroidal thickening. Now with this clinical picture in front of you, I'm sure that all those examples Megha took us through whenever dealing with a patient with exudative retinopathy, we know that we are dealing with something inflammatory because we see here hyperreflective dots in the choroid, then you see a hot disk, and you see increased sclerochoroidal, the thickening, which is very prominent on B scan. So we know that probably we are dealing either with a VKH or a posterior scleritis. So does FFA help in differentiating posterior scleritis from VKH disease? Yes, you have to look for the fluorescence pattern. If you see this presence of pinpoint hyperfluorescence with absence of these very typical early hyperfluorescences, you think of a non-infectious posterior scleritis, because VKH would usually have these early hyperfluorescence on their FFA pictures. So was this a case of bilateral posterior scleritis? Because we didn't see any early hyperfluorescences. Possibly yes. So the reasons that I would give to my diagnosis or to my conclusion is because there was absence of this typical FFA picture as one has described for a VKH disease. Then one can argue, but there was no typical STF that was seen on a B scan. So it can be possible due to two reasons. Now, in our case, the patient was already on immunosuppression. Second thing can be, not every case of posterior scleritis will have an STF. Mild cases of posterior scleritis may not have a STF, a typical subtenance fluid at the posterior pole on B scan. So hence possibility of a bilateral posterior scleritis more than VKH disease cannot be ruled out. So this is how convergent thinking acts. Basically, you take all that available clinical picture, history, every part of detail which is available to you and try to come to a possible conclusion with the help of correct logical reasoning, and basically you try to back it up with literature as well. So this is first example. Now let me take you through the second example. So second example is that of a CNVM. Now this is the same picture which Anamika first showed you, and a concrete mind would say it's a CNVM and stop there. But Megha told us that no, it's not just a CNVM, let us try to figure out more. And she then pointed towards these angioid streaks and told us that it is CNVM secondary to angioid streak. Now, what happened when we looked into the history of this patient? The patient, basically physical examination and history revealed multiple bony deformities. So this was a patient of angioid streaks in Paget's disease. So what happens in Paget's disease is they tend to have because of the early onset, they tend to have a severe bone involvement, as well as because it is an early onset pathology, there is higher risk of angioid streaks in CNVM. So having understood about this second case, so we have dealt with the exudative retinopathy, we have dealt with CNVM. Let me take you the third example of the same endophthalmitis patient, which first Anamika said that this is acute post-op endogenous endophthalmitis. But then Megha told that you just don't stop there. You analyze the picture. So seeing the sclerocorneal involvement and the hypopia, the corneal edema, the loss of red reflex and all those, and the vision, we knew that this is not a simple acute post-op endogenous, but a one which is with the microbial keratitis and a high virulent organisms, most probably. So the patient then was underwent a vitreous biopsy and an IOAB. But what happened is, although you can see the hypopia reduced in size, but the sclerocorneal involvement which was there has rather worsened here. So what is it? What is causing the worsening of the organism of the infection despite being on treatment? So the vitreous biopsy, the smear did not give us anything, but the culture showed positive group GPC, basically gram-positive cocci groups, and it was a Staphylococcus aureus. So antibiotic sensitivity profile showed us that this was not a simple Staph aureus, but a VRSA. It was a vancomycin-resistant Staphylococcus aureus. So now do we stop here? No, let us try to see what was the source of this infection. Let us converge further. So this was not just a sclerocorneal involvement, but there was a virulent organism which had multi-drug resistance, which was vancomycin resistant. So what we did is we went ahead and tried to look for the source of this infection. So when a nasal swab was taken, it also showed presence of Staph aureus with a similar antibiotic sensitivity profile, which was also a vancomycin resistant one. So then we converged to that the patient was nothing but an asymptomatic nasal carrier of VRSA. So we need to treat the source, then treat the surface and treat the endophthalmitis. And that is how, with proper treatment, a picture which looked like this after the first IOAB, with correct treatment and correct identification of the organism, the patient improved with a very good vision of 21-25. The fundus was visible and the infection was very easy, not very easily, but definitely it took a lot of efforts. But yeah, with the correct reasoning and treatment, we could reach we could eradicate the infection from the eye. Okay, so having understood about convergent thinking, let me take you through the next part, or the last type of thinking of today's session, that is creative thinking. Now, creative thinking, the name itself says, looking out for new ideas and concepts based on your past learning and experiences. Now, in contrary to breaking the information that we were doing in analytical thinking, what we do here is we break down the information, but then again, we try to put it together in a new and imaginative way. This can happen by either doing, there can be a fusion of two existing ideas, there can be a formulation of a new concept, or this can just be a spark of intuition. Creative thinking, as the word says, means thinking outside the box. It has the ability to perceive patterns that are not obvious. Creative thinking might mean devising new ways to carry out tasks, solve problems, and meet challenges. It brings a fresh perspective to your work. So let me give you a tip of the day here. Now, creativity, just don't get carried away by the term creativity that, maybe it is the one which is just limited to the artistic types. No, creative thinking isn't the one which is limited to artistic types. It is just like any other skill. It is a skill that any one of us can nurture and develop. Now, let us go through a few case scenarios exemplifying what creative thinking is. So this was a patient here. You can see these 4 macular photograph of the patient showing basically parafoveal graying here at baseline. Again, at 15 seconds, you see there is some reduction if you compare it to the baseline. Now, after 30 seconds, it has almost disappeared, this parafoveal graying. However, after 15 minutes of dark adaptation, there is this reappearance of parafoveal graying. So this is nothing but a case of parafoveal telangiectasia. And what you see is a phenomena that this parafoveal graying was reducing in its appearance, and slowly it got disappeared. However, after dark adaptation, it reappeared. So this phenomena was, although PFT has been with us for a very long time now, but this novel clinical sign, which was already there, was picked up by someone because someone who had a different eye towards it, who wanted to look for it, something you keep on observing. So then it was thought that probably this phenomena occurs due to a possible photochemical reaction occurring due to the release of chromophores from the abnormal Muller cells. So this is how how creative thinking can lead to some novelty in already existing clinical conditions, or may help you devise new ways of treating things, right? Okay, so let me take you to the second example now here. So again, a 51-year-old male with anterior chamber cellular reaction, having this vitritis. You can see here there is some form of media haze, then there's a depigmented, this clover leaf shaped chorioretinal atrophy, within which you see this active chorioretinitis, which is marked by these white arrows. Now, this patient basically had a active chorioretinitis within a chorioretinal atrophy, along with vitritis. So this patient, when investigated systemically, had tested to be positive for MON2. He had X-ray suggestive of opacity secondary to pulmonary TB. Then his PCR on vitreous sample also tested to be positive for MTB. The patient was started on ATT for 6 months. And what happens after treatment is there was resolved vitritis, the retinitis patch resolved. And now what you can see is just this depigmented patch of chorioretinal atrophy. Now, this experience happened again and again when someone saw that possibly, this is something which is common to these TB patients. So that is how, by these repeated learning experiences, we came to a conclusion that probably this can be considered as a specific sign itself pointing towards the diagnosis of intraocular tuberculosis, especially in a TB endemic country like ours. So now let me take you through the final example of the creative thinking, is that of this 62-year-old diabetic male. Now you see he underwent cataract IOL surgery 9 weeks back. His vision is good, 20/30. Anterior chamber shows a cellular reaction. You can see this hyperpane, basically feathery, browny exudate, which is there, right? Because of its margin, this itself, the structure itself, that probably it's fungal, but it was also confirmed. So this sample was taken and tested, and it came out to be a fungal endophthalmitis, basically a low virulent delayed fungal endophthalmitis, which was again treated. So even the if you see in this picture, the iris was excised, but still, if you see, it kept coming back in the form of recurrences, despite being treated with the intraocular antifungals, systemic treatment. And the patient did not want to get rid of the IOL. So that was the problem here. Now the patient, because obviously the vision was good, So what we did is we tried doing a cryotherapy to it. So cryo application was done, covering 1 clock hour on either side of this exudated, this area. And after this cryotherapy, successfully, we could get rid of the fungal infection without having to actually remove the intraocular lens. So, and then this is already published in literature. So this is how one can, with your experiences, try to see if something works, try to be novel in your approach. So this is what is creative thinking. Now, taking what we learned from this case, there was this another lady who had this infectious scleritis, who was going into panophthalmitis and was in a lot of pain. Despite taking samples, trying to find out what is causing this organism, nothing was getting picked up. So then we thought, okay, why not let us try to apply that same thing which we learned. We did a same procedure, did the cryotherapy for her. And with cryotherapy and the systemic antibiotics, slowly we could get rid of the infection. So this is how learning from past experiences helps us in our clinical practice. So let me give you a few key takeaways from this presentation. So convergent thinking is putting different pieces of information in a logical and an organized manner to reach an appropriate diagnosis or conclusion. However, creative thinking is the ability to consider something in a new way. It includes analysis, open-mindedness, problem solving, organization, and correct communication. So let's reflect what convergent thinking. I took you through 3 cases, each one of exudative retinopathy, where the patient VKH versus posterior scleritis, and we did how we logically came to a conclusion that probably it is posterior scleritis more than VKH. Second was that of a CNVM, where how history and physical examination helped us diagnose CNVM. It's not just a simple CNVM, but an angioid streak CNVM secondary to Paget's disease. And third, of a post-op endophthalmitis, where we tried to converge our thought process and were able to find out the source of this infection. The second part of the presentation was on creative thinking, where we dealt with the novel sign of parafoveal telangiectasia, that how with someone trying to, you just need to observe. You keep observing and you'll be able to find out that probably something here is different, and you keep looking for it and you'll be able to find it. Second example was that of how chorioretinitis became a specific sign of intraocular tuberculosis. And third was regarding the use of this cryotherapy in cases with recalcitrant endophthalmitis. So once again, before we go to the next session, let me reiterate which were the 6 types of thinking. First was concrete thinking, which is thinking in its simplest form. What you see immediately and what comes to your mind is concrete thinking. It has nothing beyond that. Abstract thinking is when you try to put a picture to it, when you try to reflect it, when you try to think or try to compare it with something or what it symbolizes, is abstract thinking. Analytical thinking is breaking down a given clinical picture into parts and trying to understand what it says, and that makes your job very easy to come to a conclusion. Divergent thinking involves creativity. You need to think of multiple possible solutions that can be for a given problem. However, convergent thinking was now how do we come to a single best conclusion when you have so many options there? So it involves logical reasoning. And finally, creative thinking is thinking outside the box. Just have an eye for it, keep looking at it, keep observing, keep learning from your past experiences. And creative thinking is, once again, I need to tell you that it's a skill we all can nurture. So we saw about concrete thinking, a simple example of CNVM, abstract thinking, the example, Anamika told us the example of how a horseshoe is there, for how horseshoe tear was named as a horseshoe tear. Then analytical thinking is breaking down this picture of CNVM, where there are presence of these pure day orange appearance, angioid streaks, and not just stay at CNVM, but try to break that picture and look for a cause. Divergent thinking about looking for different possible solutions which could be there to a given problem. Convergent thinking is how here we came, CNVM is not just CNVM, but a CNVM secondary to Paget's disease. And finally, creative thinking is you keep learning from your past experiences, keep making new observations, keep observing, and you'll be able to, develop this skill within you. So with this, before I conclude, let me leave you with this question to ponder over: what is critical thinking? Thank you.
Thank you very much, Prabjor. That was another amazing talk. I would request Dr. Avinash to take over and connect them with some clinical relevant issues and discuss it further.
Yeah, thank you, Chitra. And by this time, we would have, all of us would have understood the various types of thinking. We would have used it at some point of time in our life whenever we see patients. This is just an putting together in a very systematic way. Next time when you see a patient, there is a process which we follow so that we can have a good ending to it. So with that, we move on to the next session. And next session involves where we have case discussions. So there will be 4 processes involved in it. So first we would have a case vignette, that is the introduction of the case. And with that, there will also be an introduction of how a thought process could be applied to that case. And third would be a clinical pearls relevant to that case. And fourth would be a faculty from one of the panel who would be discussing on the case. So after that, Dr. Chitra Ramurthy would be having a question to ask one of the panel members. And if time permits, we'll be able to sum up the key points which we generate from each of these case discussions. So over to you, girls.
Thank you, sir.
Avinash, can I just say a few points before we go in? Are we discussing the clinical cases now?
Absolutely.
Yeah. So I just wanted to tell this is one of the beautiful way which because Chanakya also happens to be one of my favorite, and this is one of my favorite book called as Corporate Chanakya, written by the Radhakrishna Pillai. And Anvikshiki, what Anamika was telling is actually, I just want, I'll just take 30 seconds of time. If you all know Chanakya and how Dr. Avinash has brought that Chanakya kind of things to our retinal and how we need to look about all these kind of thinkings, because he's the one who people say he's cunning because it's a Chanakya Niti and he has written Arthashastra and everything. But actually he's the one who was very calculative and who knew what his next move was. His enemy never tried to predict what his next move was. So similar applies to the postgraduates here. Like, so you have one case where Megha Gulati very nicely explained, a case where it's a bullous central serous retinopathy, where there is a central fibrin which is clearing with a bullous retinal detachment and pachychoroid, where she could say that there is no much tessellations in the fundus. That's why it is a pachychoroid. And when she grouped together, that's a kind of analytical thinking. And that's what Anamika was telling is Anvikshiki is nothing but it's a practical philosophy. So that is how, where he described, Chanakya described into 4, that is Anvikshiki, the Vedatrayi, Dharma, Varta, Dandaniti. So I think this is a good way where the mythology has been brought in and it's tried to put it into our science. And congrats to LVP team. You people have done a wonderful job in how our ancestors or ancient people who have struggled a lot and try to finalize and focus on that. Thank you very much for that.
Thank you, Srinivas.
Thank you, sir, for those encouraging words. So now I start with our clinical scenarios. So as we deal with healthcare and patient care, it requires the best thinking and perfect decision making. There is no compromise in that. So today, with the help of clinical scenarios, I, Prabjot, and Anamika will help you identify how each type of thinking can contribute to easy and effective learning. So starting with our first clinical scenario. 52 years old male who was a known case of hypertension presented to our OPD with right eye blurring of vision since last 10 days. This is the fundus photo which is available to us. Now here I would like to request Anamika. Anamika, what is your thought process after seeing this clinical photo?
Thanks, Megha, for the question. So I would refrain to comment that, Megha, I'm looking at a retinal vein occlusion. I know you'll come and tell me that, oh, this is concrete. Start analyzing. So I'll start doing that now. So for any mind or for any trained eye viewer, when you're looking at this lot of exuberant hemorrhages which are emanating from the optic disc, it's very easy to come to a diagnosis of a retinal vein occlusion. But now when I look at it, so I understand it's right eye and there are hemorrhages which are some dark blotchy which are emanating from the disc, and they are kind of peripheral dot hemorrhages when they go extend up till the periphery. I also see the presence of this yellowish lesions, which are at the superotemporal aspect, which Megha is pointing to right now, which are the cotton wool spot. And now the third thing that I'm looking at here is this yellow dot with the surrounding. I'm assuming that there is a neurosensory detachment here. So what I'm looking at here, it's a major superotemporal branch retinal vein occlusion, and the risk factors being the, I think you mentioned hypertension, right, Megha?
Yeah, Anamika. So
All
thank you
right.
so
So
much.
thank you.
Yeah, thank you so much. So we were dealing with a case of superotemporal branch retinal vein occlusion with cystoid macular edema. And the risk factors for this patient were age and hypertension, very rightly pointed out by Anamika after deeply analyzing the fundus photo. Now, same was applied and patient was treated with intravitreal anti-VEGF injections. After 3 anti-VEGF injections, patient was doing very good, visual acuity improved to 20/20, and 6, the retinal hemorrhages were resolving. Now, after 5 months of initial presentation, patient again presented with diminution of vision, and this is what the clinical scenario is now. Now, patient presented with this clinical picture. Now, seeing this whole clinical scenario, here I would like to request Prabjor. Prabjot, what will be your thought process after patient presents to you with this again diminution of vision after 5 months of initial presentation and after being treated with anti-VEGF?
Thanks, Megha. So what I would see here is that the patient first had a superotemporal BR view, then resolved, or get the CMA resolved, and then again he had a BR view in the inferotemporal quadrant. So this is a patient of a recurrent retinal vein occlusion, retinal vascular occlusions. Now, when there is the recurrences that happen, that basically raises a red flag. Now, if you have, you know that now you have to look into something deeper. So if I'm sure investigations must have been done at the first visit itself, but if the patient was properly sent to a physician, consult was done, whether he was the systemic profile has been adequately controlled, whatever were risk were his or her risk factors, were they taken care of, is first thing that I would do. Second thing, I would also ask for probably because it's a recurrent vein occlusion, I need to see whether the patient is obese, whether there is history of nighttime awakenings, whether there is a history of daytime drowsiness, whether the patient has history of snoring. Now, history of snoring sometimes, usually doesn't come from the patient, but will come from the attender or, patient's partner or any of the family member who would say that, yes, probably the patient snores a lot. So that might need, I might need to rule out obstructive sleep apnea. So this is how I would like to now go into whether I have dealt with the risk factor correctly and adequately.
Thank you so much, Prabjot. It was an excellent thought process. Rightly said, patient was asked for symptoms of obstructive sleep apnea and patient gave the history of the same. So we were dealing with a case of major superotemporal branch retinal vein occlusion, and then Anamika analyzed it. But the red flag was raised when there was an episode of recurrence in the same eye. And then following the history, we were able to rule out that patient was not only having age and hypertension, but obstructive sleep apnea as the risk factor for this clinical situation. So now, as we have dealt with the case of recurrent retinal vein occlusion, I will quickly take you through 3 important clinical pearls related to it. So whenever we have a recurrent retinal vein occlusion, we always have to rule out obstructive sleep apnea, else than what the risk factor patients already have. So what will be the symptoms which we should ask the patient for? They can be excessive daytime sleepiness. We should ask the patient's partner for history of loud snoring, which is there. Then there can be abrupt nighttime awakenings. And these awakening episodes can be associated with episodes of choking or gasping. Then patient might get up with dry mouth or sore throat. These will point towards that patient might be having obstructive sleep apnea. But then how to confirm it? Whenever you're having such suspicion, send the patient and do a polysomnography. Now, polysomnography will show that there is deranged apnea hypopnea index. Whenever there is deranged apnea hypopnea index, along with excessive daytime sleepiness, this is hallmark of obstructive sleep apnea. Then what will be the treatment for these patients? These patients do very well with CPAP therapy, that is continuous positive airway pressure therapy. So the treatment has to be, in addition to the ocular treatment, the CPAP therapy in these patients. Now, we have seen cotton wool spots in our first clinical situation. Now, how are these cotton wool spots located in a case of retinal vein occlusion? Now, they ring around the optic nerve in the distribution of radial peripapillary capillaries. And this annular band of cotton wool spots in this ring form is what is called the ischemic penumbra. Now, we have seen a case of branch retinal vein occlusion. Now, whether neovascularization is common in patients of branch retinal vein occlusion, it is not common, but it can be seen in up to 25% of the cases. Now, which are these patients who go into neovascularization stage? Now, we have major BRVO and macular BRVO. It is almost never seen in patients with macular BRVO, but it is common in patients with major BRVO. And it will usually be seen in patients where there is no posterior vitreous detachment. Then what is the location? In comparison to anterior segment, posterior segment neovascularization is more common. And in the posterior segment, it is the neovascularization elsewhere, which is more common than the neovascularization of disc. And if not treated in time, 5 to 7% of patients can go into vitreous hemorrhage stage. So these were the 3 clinical pearls associated with this clinical scenario. Now here I would like to invite and request Dr. Ashra Nair. What would be your way forward in terms of diagnosis and treatment in such a clinical scenario of recurrent retinal vein occlusion?
Thanks, Megha. So, as you have already very well illustrated all the clinical signs, and there is no brainer in the diagnosis of a branch retinal vein occlusion. But like, can go to the first picture of, yeah. So in this picture, when a patient comes with branch retinal vein occlusion, we know that the most common type is supratemporal quadrant, which is about 66% of cases. Yes, and patient has hypertension, which is one of the strongest reason for why the patient gets branch retinal vein occlusion. But we traditionally know that when hypertension is there, there is also a concomitant hypertensive retinopathy. So if we just treat this BRVO with the cystoid macular edema straight away, we might be missing a lot of things, as we have already been taught in our training that we should be observant of each and small clinical detail. So if you look at in the lower arcade, there is a small AV crossing. So it is where the that one. So there is a proximal venule which is got dilated, and at that the AV crossing, even the obliteration of the venule is there. So the other sign, which the triad of pre-thrombotic sign of Bonnet, like the hemorrhage at the obliteration of venule, is not there. But these two things, if we had identified much earlier than the second vein occlusion, maybe we could have even deeply investigated even the sleep apnea as well, which could have triggered the whole thing. So that at that point there is a common adventitial sheet, and that is where if you go to the next slide, so there is vein occlusion subsequently. But you can also observe that whenever the occlusion is away from the disc, the edema is much lesser. So you also showed about the yellow dot sign, which Anamika mentioned. When the occlusion is much closer to the optic disc, the edema is much more. But whenever the occlusion is away from the disc, the edema is not as much as it is in the first case. So these two things have are the two things which could have been noticed. And you also mentioned about ischemic penumbra. So this is again a very important concept because we generally, like after when we come into clinical practice, we don't really go and dwell on the pathophysiology of how these things happen. So see, basically there is a vein occlusion here, So there is an in any shadow there is an umbra and a penumbra. Umbra is absolute shadow, and there is a penumbra region where there's a small fringe of translucency in that shadow. So similarly, when there is an occlusion, there is one area of complete occlusion and one area of perfusion. So there is a transient area where there is some amount of perfusion happening. So when there is a immediate occlusion, so because of the auto-regulation, the choriocapillaries which are supplying the prelaminar area of the optic disc, they due to auto-regulation, they the nitric oxide gets released and there is dilatation. So due to which there is some area of perfusion around the disc and some area of complete non-perfusion distal to this area. And in this area, there is this cottonwool spots, which is being mentioned, which actually mark those focal areas of axonomic stasis of these nerves. So that is where these cottonwool spots are found. So they reflect ischemia. So when there is a reperfusion, these things disappear. So these things have to be noted, and this pre-thrombotic sign of Bonnet is something which Avinash sir has been telling for decades now. So which we have to observe in our clinical examination, especially in cases of BRBO. Megha.
A very simple question, Ashray, in this. We do know that recurrent vein occlusions are not very common. But supposing we have a bilateral vein occlusion, what would be those extra things which you would have to think of?
Remember, usually bilateral can occur in 5 to 6% of cases. One of the main causes is thrombophilia, which we should rule out in these kind of cases. Another thing is hyperviscosity and hypercoagulable states have to be ruled out, investigated and ruled out. So, of course, simple straightforward case doesn't need extravagant workup, but especially bilateral and recurrent cases should be worked out in more detail.
Thank you.
Right. Thank you so much. There was a plethora of information which was available. What appeared as a simple, innocuous superior temporal branch retinal vein occlusion led on to so many clinical findings. So just to reiterate few of them. So we had a patient who had a recurrent branch retinal vein occlusion. We had this clinical observation which was told the vein occlusion, if it happens closer to the disc, the higher chance of neovascularization. If the vein occlusion goes away from the disc, the lesser the chance of neovascularization. And the point here, what Ashray mentioned, is the lesser the chance of macular edema also. So this is what we can keep in mind. And the second clinical observation is pre-thrombotic sign of Bonnet, which would help us predict that these patients are more prone to develop vein occlusion in the near future when you observe this sign. Now, having spoken about these two, Anamika did mention about the yellow dot in the center of the fovea. So this requires some sort of, in the sense you have to magnify and look at it. And if you see an yellow dot, it signifies it's a clinical marker for a presence of a cystoid macular edema. And this is not seen in chronic cystoid macular edema. So if you get to see an yellow dot, it is a harbinger of an acute cystoid macular edema in process. So having spoken about the location of the vein occlusion, the type of hemorrhages, the yellow dot, pre-thrombotic sign of Bonnet, we go on to having the red flag signs in vascular occlusion. So we discussed about recurrent vascular occlusion, venous occlusion, which is a red flag sign. The second, which what Chitra had mentioned about, if it's a bilateral venous occlusion, again, that's the third, again, there's a second red flag sign which we have to be concerned about. And third, but not the least, if there is a vein occlusion which is associated with arterial occlusion, that's a third red flag sign which points out towards a possibility of a sinister etiological factor much more than in hypertension and diabetes in such kind of cases. So having said about these important clinical manifestations, so to reiterate few of the clinical pearls, we had also discussed about, Megha discussed about the ischemic and the penumbra area of the radial peripapillary vessels, where Akshaya very beautifully mentioned about how the auto-regulation, which is there, partial auto-regulation is there over the disc area, because disc is supplied both with the retinal blood vessels and also from the choroidal blood vessels. That's why the disc has partial amount of auto-regulation which is there. And these are the important points by which one would be able to add more value when they get to see a patient with a simple, what seemed to be a simple retinal vascular occlusion, can throw more insight into it. So those are the takeaways for the first discussions. We'll move on to the second case.
Thank you, Dr. Avinash, for the crisp summary of the beautiful learnings that we had with the case 1. Now, allow me to take all of you to the case 2, which is about a 54-year-old male who had come to us with the complaints of a diminution of vision for past 1 week. At the time of presentation, his visual acuity was 20/60 and 12. And when we looked into the history, he had no known systemic illness. Now, what we are looking at here, it's a fundus photograph of a left eye, where we can see that there's a kind of a disc hyperemia. There's a peripapillary cotton wool spots. We can appreciate that there are dilated vessels. We can see this tomato splash appearance, which I was hinting on, the abstract thinking. And so the diagnosis is pretty easy in this, because it's a case of a left eye CRVO, and we can see that there is a presence of this slight NSD, neurosensitive detachment, and a presence of this cystoid macular edema. So this patient was treated with anti-VEGF, but what happens after a while is that he comes back again to us. Now, he had a presentation like this, where the hemorrhages were more, and at this time, the patient came and said that he had a diminished vision. But at this time, not only the diminished vision, he was also complaining of the pain. Vision had drastically dropped down to counting fingers at 1 meter, and he had intraocular pressure of 56 mm of mercury, and gonio showed the presence of neovascularization of the iris and as well as the angles. And this is the OCT which was there, was done when the patient presented in this particular visit. So at this juncture, I would like to request Megha to come and give us her thought process, that when she's looking at it, how is she going to go about it? What is actually happening in her mind? Over to you, Megs.
Thank you so much, Anamika, for this clinical scenario. So now, initially, when the patient presented with this clinical picture, it was a non-ischemic CRU with cystoid macular edema. It was straightforward. Patient are having these flame-shaped peripapillary hemorrhages, and in the periphery, we were able to see the dark dot blot hemorrhages, right? And the cotton wool spots were more evident. Now, although in this second clinical picture, what patient presented now with pain and diminution of vision, the cotton wool spots have resolved or are resolving. But then what we can see that the retinal hemorrhages, they are now much more prominent, and now they are not fresh. They are into different stages of healing. But what we can see are these dark blotchy hemorrhages at the macula and these tortuous veins what are there. On OCT, when it was a CME, acute CME with NST at the initial visit, now we can see the inner retinal hyperreflectivity, and I'm not able to make out the inner retinal layers. Now this might be because of those retinal hemorrhages, as I can see the back shadowing also, but still there is the amount of drill or disorganized inner retinal layers which are present. Now you tell me that the patient's IOP is high, as well as there is neovascularization of iris and angle. Now a case which was non-ischemic to start with has converted into an ischemic CRVO and has gone into a neovascularization stage is what I think of seeing this clinical scenario.
Thank you, Megha. So I really like your thought process. You have already taught us not to just go with the concrete thinking, so I'm not going to dwell into that. Looking at it, somebody would think that, yes, it's looking at a CRVO, but you really broke down the fundus photograph, the understanding of the treatment and everything, and you approached to the possible diagnosis with your analytical thinking that it was indeed the ischemic CRVO, and we have seen the conversion from ischemic to the ischemic. So on that note, I would like to take all of you to the three clinical pearls. So the first and foremost, like what we had seen in this photograph, that second time when the patient presented had a lot of hemorrhages, and somebody may think that what's happening here. So is it really possible to diagnose ischemic status of the central retinal vein occlusion based on hemorrhages? Well, the answer is no. Diagnosis of whether it's ischemic or non-ischemic is not based on the observation, but rather there are the constellation of the clinical features. Like what we had seen in our patient, there was a drop in the visual acuity. Generally, it is said it should be less than 20 by 400. Or your patient will have the presence of the REPD. The presence of the extensive retinal hemorrhages is the least reliable indicator out of all. Widespread capillary non-perfusion on fluorescein angiography is seen, and if you'll do the ERG, you'll see the B amplitude will be less than 60% of the normal. So these are the 5 pointers which will tell you that you're dealing with the ischemic or the non-ischemic CRVO. The second question is that where does the ocular neovascularization commonly occurs in a case of ischemic CRVO? I think we have actually understood this. We have seen this particular case where the conversion happened and we saw where the neovascularization really happened. So the answer is the anterior segment more in compared to the posterior segment. And the third and the last clinical poll, what I have from this session is that what is the significance of the optic disc collaterals in a case of a central retinal vein occlusion? Well, it tells you that there are reduced chances of developing the anterior segment neovascularization. So like Chanakya said that a student's ability in logical thinking should be developed first and foremost, and hence the reason he developed Anvikshiki. On this note, I would like to call upon Dr. Lalit Varma. So what would be your way forward in terms of diagnosis and treatment?
Thank you so much for having me here. Very well documented patient of CRVO. You see, we should not forget whenever we see a patient of CRVO, follow-up is very critical. The first photograph in case I can have there, when the patient had presented, if you notice there is, on the left side, the concentration of hemorrhages is mostly in the periphery. And the color of hemorrhages is not dark, blotchy kind of hemorrhages. Some of them are flame-shaped hemorrhages, but they're mostly considered in the periphery. And around the disc, we have a lot of cottonwool spots, and macula is relatively free. Although there is a whitening there, which signifies some edema, and which is confirmed on OCT and typical CME. Such patients, although non-ischemic CRVO has a relatively good prognosis, but if OCT shows CME and the vision is down, we give them anti-VEGF injections. And by and large, response is very, very good. But such patients, all patients of CRVO, you have to keep under follow-up. There is ischemic, non-ischemic. Because why I say so is because there is approximately chance of around 10 to 15% within first 6 months or so, they may convert into ischemic. So any patient of CRVO, the whole purpose of follow-up is this only, to see whether the patient is going to ischemia or not. And signs of ischemia, as was very rightly told, is not the extensiveness of hemorrhages, but I pay attention to the concentration hemorrhages mostly in the posterior pole, and also as is shown in the right side picture, and the color of hemorrhages is dark blotchy. If the number of hemorrhages, it has been mentioned that it's dark blotchy hemorrhages along with marked reduction of vision less than say 6 by 60, accompanied by RAPD. So these are the red flag signs which will tell us that such patients are. And if you happen to do angiography in this patient on the right side, on the right side photograph, you will have large, huge areas of non-perfusion. So hemorrhages alone, as was very rightly pointed out, does not tell us. If you see right photograph, number of hemorrhages, total number of hemorrhages are much lesser compared to the left picture. But the vision is markedly down. Patient has pain. Patient has anterior segment neovascularization. Other point to, as CRVO study group had taught us, the basic aim of treatment in CRVO is to prevent or treat anterior segment neovascularization. So this combination of marked visual loss, anterior segment neovascularization, RAPD, and fundus showing these dark blotchy hemorrhages
although ERG has not been done in this patient, and the OCT showing ischemia, a hyperreflective inner retina that shows ischemic kind of damage. So such patients, are typically this ischemic variety. That is the biggest fear we have. So the red flag signs are dark blotchy hemorrhages, OCT showing ischemia, marked visual loss, and no patient of CRVO should go back without slit lamp examination. Very important to see, at the pupillary margin for evidence of neoaspiration, and even gonioscopy should always be done to see angle neoaspiration.
I have one small question to ask Dr. Avinash. Since this whole conversion happens in a stepwise manner, had we done an OCT angio, what changes would it have predicted a little earlier?
It's very hard to use just an OCT angio itself for us to predict completely whether it can progress to an ischemic CRV or not. Because again, going back to the fact that it is just not based on one feature, we can do that. It's on multiple features, and all of them do not develop an ischemic progression. And all the patients who develop ischemic progression don't go on to develop neovascularization of the iris. And all patients who develop neovascularization of the iris don't go on to develop the neovascular glaucoma. That's very clearly iterated by Soon-Ching Harry. So it has to be based on multiple features. But considering the point that, when there is an extensive amount of ischemia, when you do an OCT angio, what happens is most of the deep retinal slab, if you look at the outer retinal slab, you will have an extensive capillary non-coefficient which would have set in. And that could be a marker for us to say that there is a possibility that we are looking at extensive amount of ischemia which is setting in this patient.
So absolutely, OCT angio, and people who don't have OCT angio, even a simple fluorescein angiogram, if you see marked CNP areas, non-vision areas, so that's another red flag sign to watch very, very closely. This patient may head for, ischemic, and you should always do an NTA segment. Sometimes we also do NTA segment angiography in such patients to, pick up additional neoaspiration in the iris.
Thank you, Dr. Avinash, and thank you, Dr. Lalit.
Yeah. So just to recap this case, the previous case we discussed about a simple branch retinal vein occlusion, how a etiology which is different than what was considered to be, the unique of hypertension, diabetes, especially recurrent vascular occlusion, venous occlusion. Now, in this patient, we discussed about how a simple venous occlusion, a central retinal venous occlusion, going on to becoming an ischemic. This is not something new. This is known. We have grown with or know about the 100-day glaucoma. And the point which everybody has to understand that giving anti-VEGF injections is not going to take away this risk factor. It is only going to prolong the situation. So that's the reason why every point which Dr. Lalit Varma mentioned that in the follow-up visit, it is important for us on slit lamp evaluation to check for neovascularization of the iris and also do a goni evaluation for follow-up visit is very important. And about the red flag signs which you mentioned about the change in the type of hemorrhages, where the superficials get converted to deep blotchy ones. So, and concentrating in the posterior pole, that's again a marker where we have to be careful about the ischemic progression. And just to reiterate the three important clinical pearls which was mentioned in the presentation, you can't make a diagnosis of central venous occlusion is ischemic or not just based on the amount of hemorrhages because it's the least reliable sign. You have to look into constellation of the features. And second is the presence of neovascularization. Anterior segment neovascularization is more common than posterior segment. So guys, next time when you make a diagnosis of posterior segment neovascularization and the etiology which happens to be CRVO, think twice before you pen it down. And the third clinical pearl is if you see an anterior segment neovascularization which can be prevented is by this Good Samaritan sign of the presence of optic disc collaterals. So with this, probably we wrap up the second case and we move on to the third case.
Thank you, Dr. Avinash. Thank you, Dr. Lalit Varma, for giving us such crisp points and takeaways. So now I would like to take you all to the third case. So now, by now, we have understood kind of a lot of things when it comes to the retinal vein occlusion. And now I have a very interesting case now. It's of a 57-year-old gentleman who had no known systemic illness, and he presented to us with a diminution of vision after 1 week of cataract surgery. Now, at this time of presentation, his visual acuity was 20/60 N18. Left eye was absolutely unremarkable. And at this time, the ocular coherence tomography showed a picture like this. So when a patient after cataract surgery comes to us, and this patient was actually referred from the cataract services to the retina to deal with the CME. So here I would like to call my colleague Prabjor. Prabjor, what are your thought process here? What's happening? How are you going to go about it?
Yeah. So Anamika, when was this patient referred? And the cataract surgery was done 1 week back. That's what you said, right?
Absolutely right.
So the patient was sent 1 week later with this type of OCT picture. Right. So possibly the clue is also right here. So I would not say that this is a pseudophakic CME or a Irvine gas CME, because it takes some time for that type of CME to develop. It takes around 4 to 6 weeks, because the inflammation that happens and the release of all those inflammatory markers like cytokines, prostaglandins, and the vasopermeable factors, for it to have an effect at posterior pole takes some time. So if a patient comes to you this early with a CME post cataract surgery, we need to look at something more. So if you have zoomed in this picture for me, so basically what I see here is a sclerosed vessel very prominently, which can be seen in the supratemporal macula, like exactly. Along with that, we see few hard exudates, shiny ES. So presence of these hard exudates and these sclerosed vessels, along with few collaterals, if you try to pick up, this shows that probably this is a patient with a tributary vein occlusion and the CME is because of the tributary vein occlusion rather than a pseudophakic CME. That is what I would do here. So
Thanks,
identify
Prabjor.
the risk factors.
Yeah, thank you so much. So indeed, so the concrete thinking would have been just to jump onto a diagnosis that, oh, I'm dealing with a cystoid macular edema, pseudophakic cystoid macular edema. And the analytical thinking would be just to actually break down, like what you did beautifully, Prabjot, that you zoomed in the images and you looked at all the signs that are present, and then you converged to your thought process that with the presence of the hard exudate, the collaterals, the presence of a very much of a sclerosed tributary vein, it's probably a tributary retinal vein occlusion, which have led to this CME. So on that note, I would like to impress upon 3 clinical pearls when it comes to a case like this. So we have just learned that what should you suspect when you see a cystoid macular edema within 1 to 2 weeks of cataract surgery? Answer is very simple. Look for another etiology, like what we did in this particular case. Now, what is the expected timeline for the Irvine gas syndrome? So, Prabjot has already touched upon this. It occurs between 6 to 8 weeks of the cataract surgery. Some people may have it between 4 to 12 weeks of cataract surgery as well. And now let me just take you through a very interesting case again, because since we are on the topic of the cystoid macular edema. So this lady, she was a 53-year-old who was again referred to us for a visual acuity when her visual acuity was 20/60 post-cataract surgery, and the diagnosis was made as a cystoid macular edema. Now, this is how it was. So, and the time of presentation, there was no active scleritis or uveitis. And just by chance, if you're wondering that why am I using these words, scleritis or uveitis, so let's just take a look at this bluish hinge discoloration here, which shows the possibility of the scleral thinning. So she was actually
Ma'am, the audio is getting disconnected.
Anamika?
Dr. Anamika, there is a bandwidth issue at your end.
Maybe she could switch off the video.
No, ma'am. I think it doesn't make any difference during the presentation. Her video is freezed also. Dr. Anamika? Dr. Anamika? She got disconnected.
She will connect with within a minute.
Yeah.
think she's back.
Picture is still frozen.
Is getting connected?
No, ma'am.
Yeah, she might be presenting through Prabjor's link just for this case.
So the interior fluid, like as and when she gets connected, it's the point which is being made is after an uneventful cataract surgery, the cystoid macular edema usually happens 8 weeks later. So, so if the macular edema happens within a week or two after cataract,
Am I audible?
Yeah.
All right, thank you. Extremely sorry, there was a technical glitch. Okay. So I was speaking about this 53-year-old lady who had reduced vision post-cataract surgery, and she was referred for the cystoid macular edema. So there was no doubt that she had a cystoid macular edema, as we can look here. But the point that I would like to impress upon is the presence of this bluishness in the sclera, because this was actually a heel case of a scleritis. And now when you're looking at the cystoid macular edema, the concrete thinking would be that I'm looking at cystoid spaces, this is CME, but look at this subtle RP undulation. So what was happening here is that if you look at the angio here, this turned out to be hot. There was this cystoid macular edema in the term of a petaloid appearance, what you can see classically, but there is something else as well. You can see a presence of this pinpoint hyperfluorescence that is there. So which kind of gives you a clue that you are dealing with a posterior segment pathology here. And then we saw the presence of the subtenons fluid here. So this was a case of a posterior scleritis recurrence post cataract surgery in a patient with anterior scleritis. So here the point of caution was it may look like a CME. You look for the RP undulation, you look for the pinpoint hyperfluorescence, and you look at the subtenons fluid here. So on that note, like what we have said, that the world as we have created is a process of our thinking, I would like to call upon our panel discussion, again, Dr. Lalit Varma, that what would be your way forward in terms of diagnosis and treatment?
So, Anamika, you have presented two case scenarios. First was with the uncomplicated surgery. Patient did not have any systemic issues, and patient presented after 1 week, which is, as you rightly said, is too early, because CME or what we call Irvine gas syndrome. Because macular edema, I can say, is a waste paper diagnosis. Macular edema is not a diagnosis at all; it's a finding. So macular edema, patient had CME in the first patient, but the timing was not diagnostic of Irvine gas syndrome. And very important finding which was picked up by Prabjor was that patient had this closed vessel in the supranasal to the macula. So that was a very important finding. So here is the astute clinician who picks up findings. You see, in a typical patient of Irvine gas syndrome post-cataract surgery, we do not have any vascular changes. So macular edema, if you find, do not jump to immediate diagnosis of Irvine gas syndrome. So look for other findings also, because macular edema can be present in a lot of other conditions like vascular diseases like diabetes or even some drugs, epinephrine and prostaglandins. They can. So whenever you see CME picture, think of other diagnosis. As I was saying, there can be inflammatory cause, vascular cause, fractional OCT has ruled out, but there are drugs. So many things are there. So CME, Irvine gas syndrome, should not be considered if patient is presenting in the first week. Irvine gas syndrome typically will have initial very good vision, say 6.966, and after a couple of weeks, like 4 to 6 weeks, by ophthalmoscopy and OCT, you will have CME. The second patient, in contrast, had a eventful cataract surgery. There was, although CME was there, but patient had an eventful surgery. So in eventful surgeries, the CME chances are pretty high, I think more than 20%. So such patients, should be suspected early, treated early. There's a way how we manage CME. There's a, what's that, NAP criteria. You have a step-ladder pattern of, but very important thing which you picked up was a bluish sclera on the temporal side. And that, I think, made you think that there's something wrong. Another important finding, can we have, you see if the temporal side is bluish sclera there, and the presence of suture per se tells you it's a eventful surgery. Presence of so many Descemet's folds means increased duration of surgery. So these are all risk factors of developing CME. Increased duration of surgery, presence of suture there, or any touch to the iris will have CME. Okay, and bluish sclera and the OCT, if we can have the OCT of this patient, where you picked up at RP indulations, because a routine OCT of a patient should not have that RP indulation. So that refers to something wrong in the posterior segment. And what was clinching was the ultrasonography, which picked up that fluid in the posterior subclinical space, and that was the diagnosis. And if you amalgamate all these findings of bluish sclera, angiography showing flower petalloid, hot disc, and temporal to the flower petalloid, there was some pinpoint which raised the doubt of some inflammatory pathology. And finally by USG, if you pick up that edema, it clinches the diagnosis of posterior sclera, and then you can explain everything based on all the findings that we are dealing with the patient of posterior scleritis. So we have two different scenarios. One is the early presentation. Never think of CME. Macular edema can have plethora of diagnosis, and the other is we have eventful surgery. The possibility of CME is very, very high. Also, CME, whenever we talk of cystoid macular edema, we should talk of clinically significant edema or non-clinical significant or angiographic edema. You see, I remember when I was in RP center, my professor asked me to do angiography in all the patients of cataract surgery. So I found out, CME in more than 60%. So angiographic CME is different than clinically significant CME. And eventful surgery, you will have at least 20-30% of possibility of CME. That's what I want to talk about.
Just one small question, Dr. Lalit. If it's a unilateral cystoid edema and the patient gives a history of PG analog, how would you predict the development of CME in these cases?
You see, by and large, the dictum is that prior to surgery, try to stop all the proximal analogs. Because we, in consultation with glaucoma colleagues, we try to stop proximal analogs and put them on acetazolamide for temporary control of pressure. That is important because for a couple of days, maybe weeks, you have to stop proximal analogs. Because proximal analogs have been blamed in causation or increased causation of CME post-cataract surgery. And then we prophylactically put them on NSA drops prior to surgery, and also post-cataract surgery we continue NSA drops for, I would prefer for 6 to 8 weeks. And the choice of NSA drops also, there are so many available, but my choice is always bromfenac because of the improved compliance because of the reduced frequency of bromfenac. So prophylactically in such patients you have to start NSA drops and post-op also, and stop prostaglandin and shift them to acetazolamide for temporary control of. And always, when surgery has been done, avoid iris touch, avoid any complication as far as possible, so that does not add to the inflammation.
Probably would you routinely do an OCT for these patients to pick up something subclinical?
Right. See, we have started doing OCT for all cataract surgery, in fact. Because you see, there was a study from Ahmedabad Basavada group also. If you do routine OCTs, at least 14%, I think he documented, where some posterior segment findings are picked up. So you are right, specifically in this patient who has history of analogs, there's an additional reason for me to do an OCT if there is a pre-existing edema there or not.
Thank you.
Yeah, thank you. And that was a very lively discussion about what we call it as one of those 20/20 surprises after cataract surgery. So the patient does not get back 20/20 vision after cataract surgery. Cystoid macular edema is one of them. And the discussion went on in terms of identifying how would we differentiate an Irvine gas from etiologies other than uh, or etiologies other than Irvine gas, which can cause to cystoid macular edema after cataract surgery. So remember that cystoid macular edema can happen because of problems in the vitreoretinal interface, can have problem because of the problems in the vascular disorders, and sometimes can have problems which is underneath the retinal pigment epithelium, like subtle neovascular membrane as well. Now, in this particular case, maybe because of the dense nucleosclerosis, which could have been pre-existing, finding out the fine sclerosed vessel could have been a difficulty for the physician who had to perform the cataract surgery. So, and that would lead on to the development or identification of cystoid macular edema. The point which is we have to understand is, even for an anterior segment surgeon, if they're not able to get to 20/20 vision in a week after an uneven full cataract surgery, go behind that cause. And that's how we can identify. And the earlier you identify, the better what it is than delaying that, it will improve and all this stuff. Now, we saw a very fine case of previous sclerosed vessels causing on a cystoid macular edema after a cataract surgery. And in another instance, for how a patient who had an anterior scleritis and after cataract surgery, the subtle RP undulations would help us to identify recurrence of a posterior scleritis, which very well documented on this pinpoint hyperfluorescence and the equilucence in the subtenon space to make us, and the subtle choroidal folds will be able to see on the angiogram, will be able to make us a diagnosis of a recurrence of the posterior scleritis. So, and then Dr. Chitra Ramamurthy brought about the question of how prostaglandins have to be handled before the cataract surgery, for which Dr. Lalit Varma answered that you would prefer to have them stop 2 or 3 weeks before the cataract surgery and then substitute with astazolamide and then resume after 4 or 6 weeks after cataract surgery. And he always would like to prefer an NSAID going along with the routine medications after cataract surgery. So good discussions. We move on to case number 4.
Really nice workup you had, all the patients.
Thank you, Dr. Avinash. So with this in detail discussion on CME, I will take you through yet another similar follow-up case. So this was a case of a 71-year-old male who presented to the OPD with complaints of red, itchy eyes, along with diminution of vision in the left eye since 6 months. Now, this patient was already on anti-glaucoma medications. The vision in the right eye was 6, 7.5, and near vision was N6. Whereas in the left eye, the vision was 6/18, and the near vision was N8. Now, with this history and visual acuity, I would like to call Megha to tell me what is your thought process here with this history and with this clinical picture.
Thank you so much, Prabjor. So now patient, if we see the symptoms, is presenting with diminution of vision since last 6 months. That means it is nothing acute at present. It is something long-standing which is there in the eye since 6 months. Now looking at the fundus photos, seeing both the disc, I can make out that there is advanced glaucomatous cupping which is present. Now right eye appears unremarkable if we see the retina. In the left eye superior-temporal, I can see something white membrane, it's something artifact or some lesion I could not make out properly. And if we see the fovea comparing to the right eye, the reflex is dull and I can see some yellowish reflex which is coming from there. So can this fundus photo be accompanied by some ocular investigation which can help us come to a conclusion in this case?
Sure. So an FFA was done which looked something like this.
Okay. So now this looks like the frame is in recirculation phase and I can see hyperfluorescence very foveally 360 surrounding the fovea in a petalloid pattern. So most likely it's a leakage, although I can't comment just on single frame. So it's a hyperfluorescence leakage, a petalloid pattern, and few hyperfluorescent dots I can see in the superior temporal arcane. I cannot make out why they are there, as well as in the inferior part of the macula. So this patient has cystoid macular edema in the left eye. Now, what can be the cause? So which anti-glaucoma medication patient is using?
The patient is on brimonidine, bimatoprost, and brinzolamide eye drops.
Okay. So sometimes prostaglandin analogs can also cause this cystoid macular edema as a side effect. But now patient is using, I hope, in both the eyes similar drops. And if patient is using in both the eyes similar drops, now why the patient is presenting with the cystoid macular edema since last 6 months in one eye only will be my question to ponder upon in this case, which I would like to work upon in this.
Yes. So very correctly, Megha, you pointed out that patient had a very subtle yellow dot in the left eye, along with the FFA showing a typical petaloid pattern with a slightly hot disc, and this cystoid space on OCT, which again backs up saying that yes, the patient did have left eye cystoid macular edema. And let me tell you, break down the thought process which Megha very beautifully went through. So what she did was analytical, right? She broke it into the different parts of the clinical picture, talking about the advanced glaucomatous disc, these dull reflex or a subtle, the white yellow dot which one can see. Along with this, although this was just probably an artifact, but she did pick it up. So that is the importance of observation skills, So not to have a good thinking process, you need to pick up all the observations and then think about it. And then the second thing which she did was convergent thinking, that with the help of these investigations, she tried to converge to what probably was the cause of CME. So let us keep pondering over that question, with which I would like to first reiterate what Socratic thinking is all about. Why, but why, and okay, but why. So this is our why for our next panelist, Dr. Muna Binde. I would like to call you upon for what is your thought process here, and why did this happen? Why did this patient have only unilateral CME despite he using PEG analogs in both the eyes? Is it something that we are missing here? What would be your thought process, and how would be your way forward in terms of diagnosis and treatment? So this is Madam's case. So Madam, I would like to call upon you and take your opinion.
Thank you, Prabjor and Avinash, for involving me here today. So we have an elderly gentleman with a history of bilateral pseudophakia, which was uncomplicated for many years. And he came with a complaint that forms almost more than half of our patients in the OPD, especially elderly people. They're always complaining of itchy eyes, red eyes. And typically we would put them on lubricants or something like olopatadine or treat them for allergic conjunctivitis. But he was on anti-glaucoma medications, and they were prostaglandin analogs. So that could very well explain his symptoms of red and itchy eyes. And most often one would just add on a lubricant rather than stop the prostaglandin analogs. But then he also had cystoid macular edema in only one eye. Now, why does he have cystoid macular edema in only one eye? If you're thinking of pseudophakic CME, it's a very long-standing pseudophakic CME, and we've already heard in the previous discussion that Irvine gas happened 6 to 8 weeks later. He did not have a YAG capsulotomy, which is another thing that can cause CME. And we know the risk factors for pseudophakic CME are history of vascular occlusions, epiretinal membranes, and pre-op PG analogs. Most importantly, diabetic retinopathy. Now, he had cataract surgery when there was nothing known about prostaglandin analogs at all. He had not had a YAG laser. He was not a diabetic. There was a small suspicion of an epiretinal membrane that was picked up on the clinical finding. Why should he have cystoid macular edema many years later? So what we need to do is put everything together. Look for complicated surgery. There was none. Could there be a pre-existing retinal condition that could affect the blood-retinal barrier? So we did an FFA and we looked at the late film, which shows us cystoid macular edema. But if you look at the earlier pictures, you see this little collateral running right across the fovea. And this was not seen in the other eye. So this patient actually had a compensated retinal vein occlusion that decompensated when he was put on prostaglandin analogs. Now, if you look at the literature, the prostaglandin analog known to cause CME is latanoprost. There is no report of bimetoprost. But then you look at all the literature and they're all RCTs, which are pharma-sponsored. So we said, why not stop and see what happens to the patient? Should bimetoprost also cause the same problem? So yes, we stopped bimetoprost. Yes, Prabjot, you can continue.
Yes, so this is what, so the PG analogs were stopped, and over a period of time, the macular edema completely was resolved in the left eye, and the patient's vision improved. So this is what finally happened to the patient, and this is how we basically, the thought process was very interesting case, madam. Thank you very much. So if there are any questions, Dr. Chitra?
No,
Dr.
nothing. Very self-explanatory, yeah.
Yeah, I think, Prabjot, when you had to discuss with Dr. Munna, she would have told you, like, it's elementary, Dr. Prabjot. So very similar to what Sherlock Holmes would have told Watson. What a fantastic diagnosis, what it could have been. Many of us would not have thought, like, why it could have been uniocular and what would be the cause of it. Now, if you go back to the montage, right, there are a lot of points which, if you can cumulatively, what was discussed is so well made out. So we had that, yeah, stay there. So if we had discussed about in the first case of cystoid macular edema, how a tributary vein occlusion, a sclerosed vessel would help us in identifying a possible cause of cystoid macular edema 1 to 2 weeks after cataract surgery. Then we went on for a scleritis. And here, this is something which is, which is really tickles the mind. Now, why uniocular? So if you see the cystoid, what was mentioned, if you see the cystoid macular edema, it's just on one side. It is not on both the sides. So when you see a tributary vein occlusion or vascular occlusion, you will be able to see the macular edema on OCT. On OCT, you are able to see the cyst only on one side, not on the other side. So that is one thing which we have to be, it shows the possibility of a vascular occlusion, especially the venous occlusion, and it occurs in the quadrant where the venous occlusion happens. Then Dr. MPB very clearly mentioned about this rare entity many of us are not aware of, the decompensation of collaterals. Decompensation of the collaterals can also cause a problem in the recurrence of macular edema or persistence of macular edema in branchial vein occlusions. And third is, this is a very important slide, I would say, especially for postgraduates, if they have to focus what Dr. Lalit Varma had mentioned, angiographic cystoid macular edema and clinically appearing. So the OCT can easily corroborate to the clinical appearance. Here you can see on angiogram the extensive perifoveal leakage of the dye. But if you on the OCT, you will be able to see the cyst are far and few. The one cyst is remaining on just one aspect of it. So that's how angiographic CME can be more extensive in appearance than what could be seen on clinical evaluation or what could be caught on OCT. That's all from my side.
Thank you. Great discussion. So we go on to our next.
Are my slides visible?
Yeah.
All right. Thank you. So we had a great discussion on cystoid macular edema, and I'm sure all of us have learned a lot. So let me take you through another very interesting case, which here the history is like she was a 56-year-old female who had come with the complaints of blurred vision only in her right eye. She denied presence of any systemic illness, and her visual acuity at the time of presentation in the right eye was 20/50 and 12. In left eye, she was 20/30 and 6. So we have a clinical photograph here, and this was the fluorescein. So at this juncture, I would like to call upon Prabjor. Prabjor, what are your thought process here when you see a person who says that they do not have any systemic illness and you see a lot of stuff? How do you go about it?
Yeah, so I agree there is very obvious neovascularization on this FFA that I can pick up on the right eye, as well as the left eye also shows some amount of CNP dropout areas along with microaneurysms, basically hyperfluorescence dot. Although the left eye fundus picture doesn't pick up, but the FFA really does help us pick up, but there is no neovascularization at all. Now, looking at this clinical picture, I would first make sure that the patient is systemically investigated. because the first thing that probably comes to my mind is, am I dealing with asymmetric diabetic retinopathy? So I would like to investigate, confirm the diagnosis, and then we need to basically send the patient for physician consult, as the patient is not aware of what she's having here.
All right, Prabjor. So again, a very concrete thought process would have been that I'm looking at a retinal neovascularization, but the way you have approached the topic, you have analyzed the angio, not of the right eye, but also of the left eye. And I think you had this question for me as well for the fluorescein angio. So when we did the fluorescein angio for this patient, her arm to retina time was delayed. And so I had a suspicion that, of course, that I'm seeing this asymmetricity, but why is that? So the two most common causes that I have learned so far is the presence of ocular ischemic syndrome, and the second is obstructive sleep apnea. So just on that, though patient was vehemently denying that she doesn't have any systemic illness, she was investigated thoroughly. And when she went to her cardiologist with her 2D echo and the carotids. So when she came up with the reports, it did show that she had a left ventricular hypertrophy, and she was started on ecosprin. And for her diabetes, she was also evaluated and was started on the treatment. So what we have seen is not something unusual. We just need to keep our eyes and brain open that when we are looking at a case of like this, where you see an asymmetricity. So on that note, let me take you to the 3 clinical pearls that are there for whenever you see an asymmetricity. So what are the causes of the asymmetrical diabetic retinopathy? There are many, but the two which I would like everybody to remember is the presence of ocular ischemic syndrome, and the second is the sleep apnea. And let me just read out the other ones, which you may, if you are really lucky, you may see other ones: chororetinal scarring, high myopia, concurrent retinal vascular diseases, again a very important one, optic atrophy, RP atrophy, unilateral recurrent panuveitis, and post-RD surgery. Now, I have mentioned this point of ocular ischemic syndrome, that I was suspecting that in my patients. So when should one really suspect clinically? Like, what are the two things that I would like to tell you that, if these are there, so just suspect ocular ischemic syndrome. So first would be the presence of the classical mid-peripheral hemorrhages, what we can see here. And the second would be the veins are dilated but not tortuous. Most of the times, people get confused when they see a CRVO and they feel that is OIS or OIS or a CRVO. So this is the clincher that would help anybody clinically. And the last point about how do you identify an old CRVO? So the answer is look into the periphery, because the hemorrhages here, they are the one which are last to resolve. So like the Socratic questioning, a very favorite, and I think is coming up beautifully in this presentation, is that you keep questioning and it takes you somewhere really beautiful. So on that note, I would like to call upon Dr. Srinivas Joshi, that what would be your way forward in terms of diagnosis and treatment?
Thank you, Anamika. You have nicely described about the case, and most of the things you have already discussed over it. But just one thing, when you showed the last 2 slides, that is one with the CRVO and the one with the OIS, the postgraduate definitely needs to know the basic classification between the two. The retinal veins are dilated but not tortuous, as she rightly said in case of OIS, but whereas in case of central retinal vein occlusion, it is both dilated and tortuous, right? And the location of the hemorrhages, that's also very important. The dot and blot hemorrhages are seen in the deeper layers, in the mid-peripheral area, especially in case of OIS, whereas the CRVO usually have flame-shaped hemorrhages, that is the nerve fiber layer. So they are at the superficial layer. And another important clue for this is the microaneurysms, right? So they are very common in cases of OIS, but very uncommon in cases of central retinal vein occlusion. So it's very important because all 3 of this, that is ocular ischemic syndrome, CRVO, and diabetic retinopathy, some of the clinical findings might mimic amongst these 3. So now coming to the previous slide as she showed is the OIS. So when should we look in for the OIS clinically? And the discussion now comes to asymmetric diabetic retinopathy. When should we call it as asymmetric diabetic retinopathy? It should be called as asymmetric in the definition. If we see, it is called if the one eye has the PDL, which very nicely she has shown. Can you show that picture, please? with one eye has a PDR with high risk characteristic, where you can see the pre-retinal hemorrhages there, right? And non-proliferative or background retinopathy or pre-proliferative or no DR in the other eye. Any of these four, if they fit in, then it is for at least 2 years. So why 2 years? Because there might be a chance that if other eye is having a non-proliferative, it might slowly become proliferative, or it might slowly progress like that of the other eye. So they have given a time window of at least 2 years. So PDR in one eye with high risk characteristics with non-proliferative or background diabetic retinopathy or pre-proliferative or no DR in other eye for more than 2 years is actual definition of asymmetric diabetic retinopathy. Regarding the causes, she has already explained most of it, but I would like to mention a little more is about the PVD and the BRVO. In case of, even in the vitrectomized eye, in case of diabetic retinopathy, where some people refer, or some books authors mention it as diabetic vitreoretinopathy. So if you remove the vitreous, sometimes we see the progression of the DR is less. And that is how explains in the cases of PVD as well. Of course, the RP atrophy, scarring, chororetinal atrophy, she has already mentioned it, anisometropia, high myopia, and cataract surgery, especially with the vitreous loss, is another important thing. If there is any uneventful cataract surgery, that also has to be mentioned and carefully looked into it. So now coming to, if it is a case of OIS, then how we need to look into it, how we need to try to diagnose a case of OIS. So usually the stenosis on or over 90% of the ipsilateral carotid artery, they actually present with OIS, or in 70% of patients with carotid obstructive disease. So 90% of the stenosis might go in for internal carotid artery, go in for OIS, whereas 70% of the patient might go in for carotid obstructive disease might go in for OIS. So as it's rightly said, eye is the window to the body, right? That means sometimes the ophthalmologist can see, oh, this is the case of OIS, they're having a mid-peripheral dot blot hemorrhages, the veins are dilated, they are not tortuous, it's the age between 50 to 80 years, it's in the mid-peripheral area, there is the capillary dropout and all these things. Then he might say, okay, this might be a case of OIS, let me send it to the radiologist to do a scanning. So eye can be a window to the body, and that is how some ophthalmologists can refer to the cardiologist to pick up if there are any cardiac anomalies. So actually this carotid artery stenosis, they have a protective development to DR. Why? It's because of lowering of the retinal perfusion pressure. So in case of OIS, she has rightly mentioned, the patients can present with mild ache, dull ache below the brow, or they might complain of metamorphopsia, phosphenes, transient ischemic attacks, amaurosis fugax kind of thing. So all these are very typical of OIS. And FFA, the most important, when she has showed that you need to mention if there is any delay in the arm retina time. So FFA, the delay in the arm retina time and the prolonged AV transit time, these are the two specific features for characteristic for OIS. And in case of ICG, it can be either two. One is the arm to choroid time and interchoroidal circulation time. So these two again might be delayed in cases of OIS. So these are the angiographic features, and ERG is also another important thing. Why? Because in case of CRAO or CRVO, they are usually by the retinal supply, right? But in case of OIS, which has a dual supply, that is, one is the choroidal circulation, retinal circulation. So it tends to decrease both the wave. The A wave, which derives from the choroidal, the B wave, which is the inner retinal wave, which takes up from the retinal artery, the retinal vein. So here the amplitude and the implicit time, amplitude is decreased in case of A wave and B wave in case of ERG. This is another one. And last two things which we need to know is ophthalmodynamometry, which is again an important question they might ask. If you know, it's better to read about ophthalmic dynamometry. It's nothing but applying the pressure on the globe and try to see the arterial pulsations on the disc, and how much pressure is required. That reflects the diastolic pressure of the ophthalmic artery. So the two imaging techniques is very important. One is the carotid Doppler. Another used to be the intra-arterial carotid angiography. That's what is called as a DSA, digital subtraction angiography. It's no longer used because it's more invasive. So carotid Doppler Doppler is very much sensitive and specific, or nearly around 100% specificity. So that should be the first line of management investigation in case when we suspect OIS. The other thing which can accentuate if there is a real good stenosis, then MR angiography or CT angiography. MR angiography is again has a very high, around 100% specificity. So MR, first one is the Doppler, CT angiography and MR angiography can definitely pick the lesions, and based on that, the neurologist can do it, or neurosurgeons can definitely refer it. They can either do an carotid endarterectomy. It's a beautiful study done by the North American symptomatic carotid endarterectomy trial, which they have shown that majority of the patient might prevent going in for stroke if we do the CEA surgeries. Or there can be, if their patients are having not compliant for the surgery, then they can do a stenting in the previous neck irradiation or radical neck surgery if they have undergone, or unstable angina or any of these things. And ECIC bypass can be done. So the patients having OIS, 50% of them have poor prognosis. And usually patients who have neomascularization of the iris or the rubeosis of the iris, they usually have vision counting finger or less than that. So NVI is the poor prognostic factor. The worst in around 80% present with NVI. The treatment goes is PRP. Again, symptomatic treatment can be done in most of these cases.
Thank you very much. I see that all the points were covered, but I also came across that unilaterally elevated intraocular pressure could also present as asymmetric diabetic retinopathy.
Yes, so, unilateral intraocular pressure is also one of the causes for the asymmetric diabetic retinopathy. And sometimes when these patients present with the case of NVG, right? So that is when we have to go in for the treatment where we can use the anti-VEGF, decrease it, do a trab, and use the anti-metabolites in these cases as the surgical line of management. But usually they have a low overall mortality rate in cases of OIS is around 40% at the age of 5 years. So it might be an ophthalmologically not so severe disease, but systemically it can cause either a myocardial kind of disease or a cerebral kind of strokes. So it's very important when we diagnose a case of OIS, they have to be continuously monitored, and the physician have to be continuously looked into these patients to decrease the mortality and the fatality.
Thank you, Srinivas. Wonderful discussion.
Yeah, thank you. That was A to Z of ocular ischemic syndrome, what we heard from Srinivas actually, and few points which everything was covered, and few points which I would say which has to be taken, especially by the postgraduates. It's the difference between venous occlusion and OIS. So tortuosity is the hallmark for venous occlusion, and non-tortuosity is, you don't get to see tortuosity in ocular ischemic syndrome. And the presence of mid-peripheral hemorrhages, and rightly pointed about the mid-peripheral aneurysms. There's not many diseases you can think about mid-peripheral aneurysms, and if you get to see one, you have to have OIS as high in your differentials. So for people who are mavericks in thinking or in curiosity, the question for you is why microaneurysms happen in the mid-peripheral area, but I'm not going to give up the answers. If you want, you can search for one. And OIS is another disease where anterior segment neovascularization is more profound than the posterior segment neovascularization. So similar to central retinal vein occlusion. And we also heard about the various etiologies amounting to asymmetricity in the presentations of diabetic retinopathy. And top among them, which can be a practical considerations, is unilateral occurrence of retinal vascular venous occlusions. Retinal venous occlusions, ocular ischemic syndrome, optic atrophy, sleep apnea have high differentials. And nevertheless, when you have a suspicion of ocular ischemic syndrome, always consider that there's a predominant systemic part of it involved here. It's just not the ocular part of it. So evaluation of the carotids, prognosticating the patient in terms of, or even referring the patient to neurologists for identification of a carotid obstruction is something which has to be high in your management armamentarium. With that, we move on to the next case. Case number 6.
Yes, sir. I will continue. So we have with us a 53-year-old female who came to our OPD, was having diabetes mellitus since last 22 years. Now, she was complaining of both eye diminution of vision since 2 months, and her visual acuity was 20/60 and 12. This is the clinical picture, what she had on fundus examination. So there were these hard exudates in the form of a succinate or a ring surrounding the fovea. And then we can see that the veins were dilated and the arterioles were attenuated. There was diffuse arterial attenuation which was noticed, and there were AV crossing changes. So although she was not having hypertension, not a known case of hypertension, but she has changes suggestive of hypertensive retinopathy. On OCT, we can see large cystic spaces in the outer nuclear layer in the subfoveal location, as well as small cystic spaces in the inner nuclear layer. And these hyperreflective dots at the outer plexiform layer corresponding with the hard exudates what we have. The patient was advised intravitreal Avastin and was explained about the sync effect that vision can drop despite treatment in this case. But then patient was lost to follow-up and then presented 2 years after the previous visit. And now the visual acuity has further deteriorated. Now this is the clinical picture when she presented at the second time. Now here, I would like to invite Prabjor. Prabjor, seeing this whole clinical scenario at the first visit and then patient presenting after 2 years with this clinical picture and further diminution of vision, what is your thought process?
Thank you, Megha. So clearly, the first thing, striking thing that I can see is enlargement of this succinate pattern of the hard exudate. And very grossly enlarged 2 years later when the patient came to us. Second thing is, first, these hard exudates, which appear like small chunks, have now become like plaques. So they have also quite increased in size. And also, I see some amount of venous stasis, or not stasis is not the right word, some amount of venous dilatation that can be seen basically, which is probably constant in both the time whenever the patient came to us. Now, this clearly shows that the patient has not had a good systemic control. So I would like to evaluate her blood sugars. In addition to them, I would like to go through the lipid profile of the patient and also look at the nephropathy status, whether the patient has developed nephropathy, which can also be an additional factor to cause this type of clinical change.
Very rightly. Thank you so much, Prabjor. So we can see the increase in the succinate ring of hard exudates along with these retinal hemorrhages which are present in the temporal macula as well as inferior macula. So now Prabjot helped us analyze this clinical picture. Seeing grossly at this fundus photo, there is no doubt that it's a diabetic macular edema. But once she has analyzed and compared the fundus photo at 2 visits, we came to a conclusion that there was a persistent venous dilatation and increase in the ring of succinate hard exudates which was there, which points towards the uncontrolled long-standing systemic parameters. So now here, with this case, I would like to concentrate on these 3 clinical pearls. So what does this increase in succinate ring of hard exudates points to? So now in this, we can see that hard exudates occur at the junction of normal retinal vasculature and abnormal retinal vasculature. So whenever we see that this hard exudate ring is increasing, that it is going away from the fovea, that means that the abnormal retinal vasculature, it is increasing in size. So now previously it was less, this has increased the abnormal retinal vasculature. So the hard exudates have been shifted to the outer side or the outer limit of the macula. So the increase in the ring of hard exudates signify that there is increase in area of dysfunctional vasculature. Now, once you have seen that this ring increased in our patient, but who are the patients in whom we see more of hard exudates in the case of diabetic macular edema? So systemic parameters, 3 important systemic parameters we have to look for in such patients: lipid profile, so dyslipidemia, renal function, renal dysfunction in these patients, and the blood pressure, especially the raised diastolic blood pressure. So these 3 systemic parameters points towards more of hard exudates in a case of diabetic macular edema when these systemic parameters accompany in a patient of diabetes mellitus. Now, in our case, we saw that there was chronic or persistent venous dilatation which was there. Now, what does this points to? So whenever in a diabetic patient, there is prolonged hyperglycemia, it results in inner retinal reduced oxygen tension. leading to abnormal venous dilatation, then increased VEGF level, leading to abnormal dysfunctional retinal vasculature. Now, this abnormal dysfunctional retinal vasculature leads to exudation of serum, and thus this chronic venous dilatation leads to the clinical scenario in our case of dysfunctional retinal vasculature. So it points towards 3H. We have to remember that they can be associated with hyperglycemia, hypoxia, or hypertension. So whenever we see chronic venous dilatation, meaning loss of venous tone, we should think of three causes: hyperglycemia, hypoxia, and hypertension. So with these three clinical pearls, I would like to invite here our esteemed speaker, Dr. Raj Narayanan, that what would be your way forward in terms of diagnosis and treatment in this case? So your thought process, please.
Yeah, thank you, Megha. I hope I'm audible.
You're audible, so very clear.
Yes, so actually very nicely analyzed this case about how the heart exudates, the ring is enlarging, and you have brought in different types of thinking, and one is definitely analytical. When you think of such cases, definitely we think of systemic control. And when we talk about systemic control, it's not necessarily just about blood sugar, as you really pointed out. And you have a patient, I have had such patients who have HbA1c of maybe 7%, which is reasonably good control. But you definitely have to look at the lipid levels as well as renal parameters. And if these kind of photographs or pictures can lead you to so many more questions. So what is exactly coming out of these blood vessels when we say leaking microaneurysms? If you do an FA in these kind of patients, what are you likely to see? And you tie it up with your past experiences. And when we say leaking microaneurysms compared to the baseline at the end of 2 years, you can clinically also see there are more and more microaneurysms within the center of this enlarging ring. But again, this brings up more questions. Now, this webinar is actually a different webinar. I'm not just giving answers here. As Avinash said, instead of giving fish or food to someone who is hungry, you teach them how to earn their food, or so that it's lifelong. So in such a situation, when you look at these photographs, what are you thinking? So is this exudate coming from the microaneurysm and going out, or is it a transudate which is going out and there is a filter at the junction of the dysfunctional vasculature and normal vasculature, which does filters out the exudate? If it had been the former, that only the exudates are coming out of the microaneurysm, you would have imagined that in the center of the leaking microaneurysm, you will have more dense hard exudates. And as you go away and away, there will be less concentration of hard exudates. But here it's not the case. Here the case is there are leaking microaneurysm within the center, but all the hard exudates are like ring fence. So that you can start thinking in an abstract way, okay, what's going on in these kind of cases? And why do they not coalesce at the same spot? At least in some other diseases, they can really coalesce and they go subretinal also. Whereas in diabetic retinopathy, they're usually intraretinal. Typically, they don't go subretinal. Why is that? Is there edema in all the dysfunctional area? We saw that OCT picture which we showed initially in the right eye, and this is a big question, right? Many books have hypothesized and some answers are there. You have lesions somewhere else, but the fovea becomes swollen up. So what are the typical physiological and anatomical features of the fovea? That the edema occurs in the macula when there are no blood vessels in the macula, or there is anterior uveitis, or there is a peripheral vasculitis, or you showed those cases of cataract, that there is a macular edema when there is no blood vessel in the macula. So does this pattern happen in an RVO? We discussed so many cases of retinal vein occlusion today. We don't get these kind of cases. Why not? So this forum, I think this webinar is a way of thinking or getting more questions while we try to find answers. We are really very, very interested in knowing more questions from these answers. And from this, yeah, obviously these patients we should evaluate systemically, and probably you will find other than sugar also there may be derangement. Now remember, as per the new AHA guidelines, dyslipidemia, while lab reports tell you the normal range for lipids, triglycerides and different types of cholesterol, as per the new guidelines, any cholesterol or triglyceride level, you have to bring it as low as possible in diabetic patients. There is no normal range. The normal for normal people is not normal for diabetics.
Thank you so much, sir, for those great thoughts. Now I will proceed. Dr. Avinash, Dr. Chitra, you have anything to comment upon?
A question not directly connected, but if this diabetic macular edema was to occur in pregnancy, if it were in the latter part of the pregnancy, would you differ in your management? If it's an earlier part of pregnancy, how would you differ? Dr. Avinash?
Okay, so if it is happening in a pregnant, so I would prefer to be in the first trimester. I would not even consider getting a fluorescein angiogram, or generally in pregnancy, I would not consider getting a fluorescein angiogram or considering an anti-VEGF to be injected in these patients. And especially in the first trimester, it's an absolute contraindication. So the remaining, it maybe we can think about, but for a diabetic macular edema, when you look at into this condition, it's not something where it's a must in 1 or 2 months, something is going to go haywire and something is go wrong. And if there is a possibility that we can, clinical acumen is good enough to pick up the microaneurysms, or we have an understanding that we can manage these conditions with laser, we can certainly. And if there is a systemic component to it, which can happen, because we know that in a pregnancy, the blood sugars can get elevated. And sometimes if they remain uncontrolled, or even if there is an increase in hypertension, so we get them in order, rest of things may fall in place once the pregnancy is over. So if there is a pregnant condition, if it's in the first trimester, I would like to avoid anti-VEGF and fluorescein angiograms. OCT is a good way by which we can go. As much as possible, stay away from the injections. If at all it needs to be treated. Again, here it is only for the ones which are visually significant. Those which are not visually significant, away from the center, we can just follow up these patients periodically once in 4 months.
Thank you.
Thank you, sir. Thank you, ma'am. Now I will proceed with the next case. So case number 7. Now this patient, who is an aged gentleman, 62 years old male. Now this patient came for routine evaluation, routine ophthalmic evaluation, and both eye best corrected visual acuity was 20/20 N6. So anterior segment showed nuclear sclerosis as expected for his age, but the posterior segment examination was almost bilaterally symmetrical, and left eye is there in front of us. So we can see multiple drusen's which are there, and they vary in size from small to medium to large confluent drusen's which are there at the macula, as well as extending just beyond the arcades also. So now this patient was labeled as high risk dry AMD and was asked to be under regular follow-up. The patient was under regular follow-up, but after 1.5 years of that presentation, patient didn't come for regular follow-up, is coming with left eye diminution of vision. Now this is the clinical picture at the second visit what we have. So now here I would like to invite Anamika. Anamika, so this was the initial presentation when patient was 20/20 N6, and this is after 1.5 years when patient is presenting with diminution of vision since last 2 weeks, and his vision has dropped to 20/100. So now what is your thought process when you compare these two fundus findings? You're not audible, Anamika, if you're there. Yeah, now you're audible.
Okay, so I was saying a very interesting case here. So any patient of dry AMD is just how I go about it, that they come with the complaints of a diminution of vision. The first and foremost thought that I have is that have they converted into the wet AMD. Now, I'm not going into the details of that, but as and when I'm looking at this 2 comparative photographs, the period of was like 2 years, right? Or 1.5 years.
1.5 years, yeah.
Yeah. So when I look at it, it's pretty evident that this clusters, this denseness of these drusen which were there at the first visit, they are not like that in the second visit when the patient has come with a drop in vision, which was 20/112. In fact, what I'm seeing is that there is a kind of a clearing. Now, is there a clearing or is there a so fluid? Is I'm just based on the photograph, I'm unable to comment. Also, just because the patient has a drop in vision, I really want to see that, but I'm unable to comment on any presence of any membrane or a subretinal hemorrhage or anything. But it would be really cool if you have a OCD image running through this section. Do you happen to have that?
Yeah, thank you, Anamika. So rightly said that we can't see any membrane or subretinal hemorrhage, which is visible clinically, but the OCT was showing this subretinal fluid and double layer sign with the subretinal hyperreflective material. So now, thank you so much, Anamika. So when Anamika analyzed this clinical picture, she noticed that there is disappearance of drusen, and this disappearance of drusen is in absence of clinically visible geographic or RP atrophy, while the OCT is showing the double layer sign and the subretinal fluid which is there. So now we came to a conclusion that a dry AMD, which was already a high risk one, has converted to a wet AMD. So now why this disappearance of drusens is there and what does it points to? Now, disappearance of drusens in the absence of geographic atrophy points towards, or we should be suspicious of, that patient is going into wet AMD or there is development of CNVM. Now, why is there disappearance of drusen? So it is hypothesized that the persistent subretinal fluid which is there acts upon the retinal pigment epithelium, and then there occurs the diffusion of that drusen material which is there in the subretinal fluid. Now, what can be the cause of diminution of vision in a patient of dry AMD, which is there, like a dry AMD patient presenting with blurred vision? What all should we think of? So now we can think of three causes. So firstly, the drusens which were there, they have coalesced, especially subfoveally when they do, then the patient can present with diminution of vision. Secondly, either they can be a new RP atrophy setting in, or they can be a progression of RP atrophy, which will lead to diminution of vision. Thirdly, as we saw in our case, that there is development of choroidal neovascularization. So these will be three differentials you have to keep in mind whenever a dry AMD patient presents to you and complains that he is having blurred vision. Right now, once we have a wet AMD or a choroidal neovascularization, what are the different FFA features? So on FFA, we can have a classic choroidal neovascularization or an occult choroidal neovascularization. Occult can be of two types. I will tell you in detail here. So classic, they are rapid fillers. So in the choroidal or in the early arterial phase itself, you will see well demarcated choroidal hyperfluorescence. And then they will be followed by leakage. That is, the hyperfluorescence will increase in size and intensity, as well as you can appreciate this lacy network or cartwheel like pattern which is there in case of classic CNVM. While in cases of occult CNVM, it can be either a fibrovascular PED, which you will see as an RP elevation clinically, or it can be late leakage from undetermined source. Now, in case of a fibrovascular PED, there will be no visible source in the early phase, but almost after 2 to 5 minutes of dye injection, you will see the speckled pattern of hyperfluorescence which will be there, and then it will increase in size in the late phases. So they are slow fillers that almost after 2 to 5 minutes of injection, they will show this speckled pattern. This is what is fibrovascular PED. And if there is late leakage of undetermined source, when do we call that? When we are able to see the hyperfluorescence in the late phase. That is, they are the slowest fillers and there is nothing what we can point out to in the early phase what is leaking. This is late leakage from undetermined source. Now, having discussed this case of conversion of dry AMD to wet AMD and having discussed the three important pearls in case of wet AMD, I would like to invite Dr. Raj Narayanan again, that what would be your way forward in terms of diagnosis and treatment in such clinical scenario of dry versus wet AMD.
Yeah, again, excellent case, Megha, in the sense that what you have shown is a very good clinical pearl, that when you have a patient with dry ARMD, and there's no obvious CNVM. First of all, I tell my residents and fellows, when someone says ARMD, CNVM, you generally as a fellow or a resident, you just can't see any CNVM. There may be hemorrhage, some PD, but typically you don't see a CNVM. Unlike an ERM or a macular, well, it's obvious, retinal detachment is obvious. But occult CNVM under the RP, it's always a challenge initially to learn. And that's where, someone has to teach you. A teacher has to teach that this, if you see, it's a CNVM. And the point here, the important point is that in the absence of geographic atrophy, if you see disappearance of drusen, disappearance is you are not able to see them. Technically or physiologically, it may still be there, but you are not able to appreciate clinically when you don't have atrophy. How do you know there is no geographic atrophy? Because you are not seeing the choroidal blood vessels there in that area where the drusens are lost. You are not seeing the typical RP atrophy, geographic atrophy, large choroidal vessels. You just see absence of drusen. Then you must suspect a CNVM. Why is it different from a regular CNVM? Because as you mentioned, regular CNVM, otherwise if you have subretinal hemorrhage, subretinal fluid, some exudates, you will be able to still make out a diagnosis of CNVM, but they are not there in this case. So you must suspect CNVM in a patient of vision loss where there is disappearance of drusen, but without obvious atrophy. And how would you manage, let's say retrospectively thinking, patients who come with the left-hand side picture at baseline with multiple drusen, some RP atrophy, high-risk ARMD patients, OCTA can be a good tool initially itself. In such case, the dry RMD, where you have this entity called non-exudative CNVM. We may or may not have a non-exudative CNVM in the patient, in this patient who came 2 years earlier, but there have been cases which have been picked up where you thought it's the slam dunk dry RMD, no CNVM, it's just drusen, and you find out that there is a CNVM on OCT angiography, as you showed in the double layer sign, maybe is there in the beginning also. So that's something you can have, and then you can have, in such cases, close monitoring, both with home AMSLR and as well as visits to the clinic. But the newer technology of home OCT also may come up in the future, where patients may be able to do a home OCT. So that's how you would probably look at these kind of patients. But again, some of the questions which can come up in way of abstract thinking or analytical thinking is, as you clearly pointed out, CNVM is a sign, it's not a disease by itself. But why does CNVM occur generally only in the macula? Is the macular choroid different from the extramacular choroid? I can tell you, in extramacular PCV, Dr. Muna can comment on that. In extramacular PCV, you generally have only polyps, whereas in macular PCV, you have polyps and BVN. We keep talking about branching vascular network. But if you have an extramacular polyp in the vascular arcade or even peripheral, we generally tend to have only polyps. Generally, you won't have a BVN. Why? And is ischemia the only reason for CNVM? That means if there is a thin choroid, does it predispose to CNVM as in ARND? But then why does CNVM occur in pachychoroid or even in euchoroid? So the overall purpose of this webinar, this could have been labeled as a retina potpourri, challenging cases, meet the experts, like the regular webinars. But this is not a regular webinar. This is about critical thinking, which we are talking here. And that, I would say that, that has been very nicely presented today by all of you. And it's not about just one thinking in one case. In one same case, you have different thinkings, and then you come to a conclusion or a diagnosis or a treatment. And it's a journey. So Ashray mentioned that concrete thinking, RVO case, it was a no-brainer. Whereas to a resident, a PG first year, it may not be very obvious, right? So what is concrete for Ashray is probably something very different for a first year PG. So that's where a teacher has to teach the student the way of thinking, and then they also progress. That becomes concrete for them. An example also, I would say that, Phil Rosenfeld, ARMD anti-VEGF treatment, how did it strike him? And then from there, it's a no-brainer now. Anti-VEGFs are left, right, center for any CNVM now. So those kind of thinking is what we need to inculcate in everyone. I mean, as Avinash pointed out, we are students lifelong. Not when you are enrolled in degree course or PG or fellowship, you are a student even beyond your PG or fellowship. And I'll just conclude that a scientific mind does not rest with one hypothesis or conclusion. Generally, we as human beings are tuned to get answer to a question, but a true scientist is interested in more questions from the answer which they are trying to get. Each answer will bring out more questions. And I know Avinash has quoted Chanakya and all, and he is also an ardent listener to Rudram from Yajurveda. And that also says that you are your thoughts actually. And why are Muna Bende or Avinash or Lalit Varma, why are they different? They think differently. All the combinations of thinking which you have brought out today. And Avinash paid tributes to Muna Bende right at the beginning. Why? Because Muna Bende has taught Avinash about abstract and analytical thinking, which is now concrete for Avinash. He can rattle off pearls and teach any of us anytime on any subject by his way of thinking. That Guru Parampara has to be maintained, and Shishya also becomes a Guru, as we have seen here. So how to think is the key question in this webinar. As you know, today's webinar is so different. Everyone has appreciated today. It's not about meeting the experts and lining a few points. Each one of us has to start to learn thinking. And that's what a guru is there. Can anyone teach us how to think? That person is your guru. With that, I would like to thank AIS, Dr. Chitra, who has done a lot of thinking and hard work for this, along with Avinash, for bringing together this symposium. Thank you very much.
Thank you very much, Dr. Rajan, but we still have 3 more cases to go, I think. You're here till then.
Sure.
That's the invisible whip which comes from Coimbatore.
Thank you so much, sir.
Dr. Chitra, you have a question for Raja actually for this case?
No. You can go on to the next case, or you could summarize it.
Yeah, just a case of summarizing, and we saw a case which has a lot of significance just with the disappearance of the drusen. So we saw some risk factors, high risk dry AMD, the 3 types of drusen in one patient, the hard drusen, the soft drusen, intermediate sized drusen. And we also looked into the pearls of what to consider when a patient with dry AMD starts losing vision. It's because of coalesced drusen, the presence of RP atrophy, and the development of neovascular membrane. And here again, like just to reiterate what Raja mentioned, that most of these neovascular membranes occur underneath the retinal pigment epithelium, not so obvious to the eye. So the subtle elevation is which would help us to identify if the patient has a decrease in vision as well. An additional point here is when you talk about the geographic atrophy, which sets in, the center of the fovea is last to be involved in geographic atrophy. So most of it starts from the paracentral area, and then our parafoveal area then involves the central of the fovea. So that's an additional point which you can use in your clinical practice. And when you look at an angiogram, though angiograms are becoming obsolete now, the speckled hyperfluorescence is a sure giveaway that you're dealing with an occult neovascular membrane. And if you can see here in the middle row, you will be able to see, Megha, can you point, you have the speckle, the dots like what you get to see, that's the one which gives away. And the slow fillers, the classic ones, because they're underneath the retinal pigment epithelium, you get to see the fluorescence much earlier. Whereas the occult, the fibroscular PD happens around 30 to 90 seconds. And the slow late leakage of undetermined source, the name has it all occurs much later. And that's the takeaway from the choroidal neovascular membrane. Choroidal neovascular membrane, it's not a diagnosis, it's a sign, and we have to pursue what would be the possible etiology of choroidal neovascular membrane. With that, we move on to the next case.
Thank you, sir. Thank you very much for summarizing that case so beautifully. So moving on to our 8th case. So this is basically a 54-year-old highly qualified professional who complained of metamorphopsia in the left eye since few days. His vision in the left eye was 6/6 partial. And this is how his clinical picture or the fundus photograph was. So here I would like to call Anamika. Anamika, can you please elaborate what is your thought process here with this history and this fundus picture in front of you?
Thank you, Prabjor. So it looks like a very interesting case. So when I just look at it, so there are three things that I'm looking at. So I'll start with the right eye. So there is this very obvious presence of RP atrophy, which is at the temporal aspect of the fovea that I'm looking at. But then there is this yellowish kind of a material is drusen or what, which I'm seeing here. And similar picture is kind of a symmetrical in the another eye as well when I look into the left eye. But also there is some yellowish teeny tiny lesions which are at the superotemporal arcade. Yes, exactly there. So just looking at it, my concrete thought would have been that am I looking at the dry AMD, because there is a presence of RP atrophy as well. But this patient has this recent complaint of metaphobopsia. So here I would like to at least see some imaging so that which would help me aid, come into a kind of a differential here, that what I'm looking at.
Sure. Absolutely correct start of this process. So these are the investigations. So you see the FFA here, the right eye and the left eye, the autofluorescence and the OCT. So this is the multimodal imaging available for you to deep dive into your thought process.
Yeah, I'm going to dive deep now. There are so many things. I'll start with the fluorescein angio. So I was looking at the RP atrophy and that is really lighting up. And I see a lot of stippled hypofluorescence, hypofluorescence that is looking. So I'm sure that the symmetrical presence that I was looking at in both eyes, it is that I'm dealing something at the level of RP. The window defect is there. And now as I gaze into the autofluorescence here, so everything is really dark here. The hypoautofluorescence that I'm looking at when I look at the right eye. But when I look at the left eye, there is a presence of this speckled hyper autofluorescence as well. A few areas are, I understand they are dark, which are hypoautofluorescence. But those subretinal yellowish, those teeny tiny lesions which were teeny tiny to my eyes, they are actually a lot when I'm looking at in the autofluorescence in the left eye superotemporal arcade here, because they are hypoautofluorescence and the surrounding area is lighting up, which it's unusual for the drusen, if because that was I was thinking actually. And now when I look at the OCT here, there is this weird presence of this sciatic spaces that are there in the right eye, and there's a presence of also a neurosensory detachment. So in the last few talks, what we have understood today, that we have learned that it would have been concrete to just call it a dry AMD, but now patient has a complaint of metamorphopsia, and he happens to have this neurosensory detachment and happens to have these changes in the outer nuclear layer, if I'm right on that part. So doesn't look like dry AMD, but doesn't look like wet AMD also to me. Do you happen to have anything more in that? Because right now I'm thinking that is there any material subfoveal that I'm kind of missing in this composite that you have shown me here?
So right here, it was the way you see, but an OCT through the inferior fovea showed this type of.
All right. So yeah, so it looks like a hyper-reflective material, I'm sure. I mean, hyper-reflective is not the correct term actually to see when we see a OCT like this, but there is something, so it could be an exudate or a membrane or a vitiliform lesion. I would like to do some electrodiagnostic procedure now to just confirm that if I'm dealing with anything related to the vitiliform lesion or not. So have you done the ERG or EOG or anything further to just understand that what's really happening at the RP level?
Right. So thank you very much, Anamika. So let me just reiterate what thought process Anamika just went through. So first, she herself mentioned that probably looking at it, is it a dry AMD? So that was sort of a concrete thinking. But next, what she did is she broke down the fundus photo into different pieces and then tried to analyze that what is it that is exactly causing metamorphosis. Is there something more to it? And then she asked me for those investigation and using the multimodal imaging. She, hello, am I audible?
Yeah, Prabjor, you are audible.
So, and then looking at the OCT and the FFA and the autofluorescence, everything, she then went into divergent thinking, basically either it is a degeneration or a dystrophy or a CSR or whatever. So that was a thought process. And then looking at that OCT, probably she said, is it something vitally formed? Should we go for a electrophysiology? So that was, now she's trying to converge to a possible diagnosis out of those multiple differentials that she had in her mind. So this was the thought process. Now with this, I will, since we were on electrophysiology, let me take you through a couple of clinical pearls on electrooculogram. So how does one read an electrooculogram? So very important is whenever you see a report of an electrooculogram, you need to very, very closely look at these saccades, because if the saccades are not good, probably the Arden ratio that you see may be a false positive or a false negative. So look at the saccades ratio, the saccades, and then that basically based on the amplitude, which is highest in the during the light and it is minimum in the dark time. So a ratio of that light peak to dark trough is what is Arden ratio. So again, reliability, to see whether it is reliable or not, you need to look at the saccades. A false Arden ratio may be present despite an electrically inactive retina. Second is, what is the role of electrooculogram when we talk about Best disease? So I would say that do not stop at Arden ratio alone. So now, for example, if you see here, so as I was mentioning, about the saccades. So you see the saccades are not very good here. But again, so the Arden ratio, if you try to see, is 2.112. But you can see what the amplitude is. It is very low amplitude. The saccades are not very reliable. However, the Arden's ratio is probably here falsely positive. But with an abnormal electrooculogram, what is normal is the electroretinogram. So whenever you have this combination of a normal electroretinogram with an abnormal electrooculogram, probably that is the best confirmatory of a Best disease. Electrooculogram may also be abnormal even in pre-vitally formed stages and amongst the carriers. So with these two clinical pearls, let me reiterate what Socrates said: I cannot teach anybody anything, I can only make them think. So with this, I would now like to invite Dr. Anand Rajendran to tell us, because this was his patient and his case, that what would be his way forward in terms of treatment and diagnosis.
So good evening, am I audible?
Yes, sir.
Yeah. So first of all, I'd like to congratulate Dr. Chitra, Dr. Avinash for setting this up, and his team of these three very bright young consultants, Prabjor, Anamika, and Megha, for putting what I think is an extraordinary webinar. It's easy to just discuss cases, but to dissect that thought process behind is critical. And that's where this webinar is making a difference. So this case is a very beautiful one. It's a very old case, actually. It's about almost a decade and a half, and you can actually make that out by the imaging, which is kind of a previous generation imaging. So this patient, just to give a little background, that he was a lawyer, very type A personality, came in with, wanted to be seen first, and, very agitated kind of guy, very educated, high court advocate, actually, Madurai. And he came in with this symptoms which was very fresh. So if you go back to that fundus photo picture, like you mentioned, so as with, one of the issues with being with consultants and as you get senior is you try to, make small spot diagnosis, which I think is what we are talking about when we talk about concrete thinking. Look at it, you see it, you make a diagnosis and be done with it. So it's been very easy to have passed it off as, I think Anamika mentioned initially, as dry AMD. And it's good that this case comes juxtaposed in the background of the previous case, which was an AMD case. So it looks, there are certain similarities to that case. There's a lot of yellowish material in a middle-aged gentleman. There's an atrophic patch there, which obviously hits you in the face like a geographic atrophy. And there's this yellowish material. So you think that it's, drusenoid material and it's this atrophy patch. Patient, the vision is not too bad, so you can pass it up. But the patient was very symptomatic in the left eye. He was very clear that he was having very good vision and he was symptomatic. And with AMD, you would expect a little more of degenerative changes. So that got me thinking that this is perhaps not as simple as it was looking. And then with his symptoms, and with that, on the slit lamp 90D by microscopy, there was an obvious serous macular detachment in the left eye. That brought in a bit of divergent thinking and brought in the possible diagnosis of a central serous posterior retinopathy, which could be possible, given the fact that he's a high stressed out person, works late hours, coming in with the sudden symptoms. So that goes thinking in that direction. Now, after that, that's where the invasive versus non-invasive. Note that this is our early era imaging, where it's all flash autofluorescence. So it came along with that. So we did fundus photography, fluorescent angiography, and then after that, the back that with also autofluorescence. So with the background of CSR, you don't have, as we saw in some cases earlier, and we discussed it earlier also in some of the differentials, you don't have the gravitational tract, don't have other signs. Yes, in the right eye, you could pass it off that sciatic retina could be a differential for a chronic CSER, but note that vision was 6.6 in that eye, and he was not at all symptomatic in that eye. And in the other eye, there were no other signs of there being atrophic lesions. But what was clinching there also was what you see on autofluorescence. And yes, we'll before we go to autofluorescence, we'll look at the OCT at the different levels, which showed this this subretinal material gravitating inferiorly. If you have that OCT at the level above, you won't find that much of material. The OCT which you showed here. If you just go back to the screen before this, you'll see this OCT on the bottom right is right at the photo you just before we did there. Yeah, that one there. So there you don't see that subretinal material accumulation, which is seen in the level below. So you know that there is something which is gravitating below and accumulating there. And then after that, what makes it chalk and cheese is the autofluorescence, which shows the streaming hyper-autofluorescent material, suggesting that there is some lipofuscin-laden material, flocculent material, which is gravitating below. Then this takes us from an age-related ARMD common diagnosis past the CSR diagnosis to another class of diseases, which is dystrophies, which is vitiliform macular dystrophies. Now, in this vitiliform macular dystrophies, this is again where one would, this is involving a bit of divergent thinking. So now you're thinking of 4 possibilities. The 2 common ones are adult vitiliform macular dystrophy and Best's dystrophy, which most people would have seen. There are 2 other rarer ones, autosomal recessive bestrophinopathy and something known as autosomal dominant vitreoretinochoroidopathy. Now, what EOG does is help in distinguishing the AVMD and the ADVIRC from Best's disease and autosomal recessive bestrophinopathy. In Best's disease and ARB, this is where the EOG will be markedly subnormal. Whereas in AVMD and ADVIRC, it's little variable. The EOG is more or less normal to subnormal. And the Ardens ratio here was 1.8 and 1.6, 1.8 and 1.9. In most EOG, in most electrophysiology labs, a value above 1.8 is kind of normal. 1.8 to 1.65 is usually considered subnormal, and below 1.65 is abnormal. So therefore, given everything put together, also of these 4 vitiliform macular dystrophies, AVMD or adult vitiliform macular dystrophy is the only one which is coming up in the middle age, whereas most of the others get to be a little more symptomatic earlier. Also, in that rarer variety, ARB, autosomal recessive bestrophinopathy, there's usually a lot more flocculent material, streaming around in the posterior pole. So this is where the divergent you have to, pin slot the diagnosis and then use convergent thinking with all these diagnoses coming in from the negative findings of fluorescein angiography, the positive findings of the OCT, and the positive finding on autofluorescence, and the positive finding on electrophysiology, to bring you to what is the best fit diagnosis, which I think is convergent thinking, which is putting clues which are atypical and then pigeonholing it to one best fit diagnosis, which in this case was probably adult onset vitiliform macular dystrophy. So an interesting case which brings out these different aspects.
Thank you very much, Doctor. Very interesting discussion.
So yes, this was a case of adult onset foveal macular vitiliform dystrophy, and we need to look through all the scans of OCT. So it's not just the scan passing through the fovea. We need to look through entire picture to come to a diagnosis.
Exactly.
Dr. Chitra, you have any questions?
Yeah.
Dr. Avinash?
Yeah, this is, I think the major takeaway is, a middle-aged man presenting with a macular problem, symmetrical problem. The differentials commonly would go towards an age-related macular degeneration because on the appearance-wise, this on the concrete thinking-wise, the analytical part of it and the convergent part of it made one to go beyond even central serous and vitiliform dystrophy to happen, and the electrophysiological pulse which came about. So I think the understanding of the occurrence of neurosensory detachment in such kind of patients of vitiliform detachment is something which we have to consider in the management of these cases. So with that, we quickly move on to the next case.
Yes. So the next case was a case of a 38-year-old female who basically came for a routine retinal evaluation post laser for lattice degeneration elsewhere. So this is her fundus photo. And Megha, I would like you to comment upon what do you see here and what is your thought process?
Thank you so much, Prabjor. Am I audible?
Yes, very much
okay.
audible.
Yeah, thank you. So now the patient has come for routine retinal evaluation, right? So patient has been treated for lattice, has been lasered for lattice. But what I can see in the periphery, I could not make out any lattice. Might be it's in near the aura or something. But what is a prominent finding in the right eye? What I can see in the temporal mid periphery is this round or oval lesion which is there. Now it looks like hypopigmented with speckled hyperpigmented dot-like lesions in it. But the margin of the lesion is hyperpigmented. So a hyperpigmented speckled lesion with hyperpigmented borders, it's oval lesion. And then I can see a hyperpigmented extension, which is pointing towards the fovea. Now, such similar lesion is seen superior to it as well as along the inferior temporal arcade. Now, both these lesions also have this hyperpigmented extension, which is now, I think, pointing towards the disc. So all three have this hyperpigmented extensions pointing towards the posterior pole of the disc. Similarly, in the left eye, although such a large lesion is not present, but smaller lesions are seen, which are symmetrical to what is seen in the right eye. So now I think this is the case of congenital hypertrophy of retinal pigment epithelium because it looks like that only with this lacunae-like appearance, but it has this hyperpigmented extension. Now it is bilateral and it is, I think, multifocal. 3 I can appreciate in right eye and 2 in left eye. So bilateral multifocal chirpy will be my answer to this question.
Thank you, Megha. Very beautifully, you have once again showed how analytical thinking works. So very, very nicely elaborated on how basically we have to look through each and every part of the clinical picture that is there. So very beautifully again described how a chirpy lesion is in this clinical picture. And it is not just multifocal, but it is bilateral. So with this, let me take you through few clinical pearls related to chirpy. So first one will be, how does a chirpy in Gardner syndrome look like? So an oval-shaped peripheral lesion with this hypopigmented fishtail extension at its end. Because it is oval, the oval shape will have two ends, right? So at the end, if you see this hypopigmented fishtail extension, this is very typical of a chirpy in Gardner syndrome. And along with that, you see these hypopigmented, depigmented lacunae, within the lesion, and there can be this occasional hyperpigmentation around it. And whenever these lesions are multiple or bilateral, it's very specific for Gardner syndrome. Second is, what are bear tracks in fundus? So they are nothing but grouped type congenital pigmented nevi of RPE. They are called bear track because they represent footprint of the animals, with the smaller spots which are presented or located at the apex directed posteriorly. The third one in the same sequence would be, then how does one recognize a polar bear track sign in retina? So just as its name suggests, they are also basically RPE nevi, but they are hypopigmented or depigmented, and that's the reason they're called polar bear track. They can be variably sized, present all through the peripheral fundus. However, macula is relatively spared in these eyes. So with this, I would now call upon Dr. Muna Bhende. Ma'am, this patient was ma'am's case. So, ma'am, how would be your way forward in terms of treatment and diagnosis in this patient?
Yeah, thank you, Prabjot. Basically, we tend not to look at these innocuous lesions in the periphery. And what is more dramatic is the bear tracks. When we see clusters of them, we always think, oh, the patient must be having Gardner syndrome. But it's not true. It's the chirpy lesions that are part of an entity called familial adenomatous polyposis, which has very sinister connotations. And like you mentioned, it's very common for us to see one chirpy in the periphery, but you see clusters like this in all quadrants. The pictures are not quite going to the periphery because this was a slightly older patient. She had laser in both eyes, and these were the pictures in both the eyes. So the lesions themselves are innocuous. They don't grow, they don't become malignant. Whereas sometimes isolated chirpy lesions can become malignant. But a lesion like this, that is pisiform with that tail, with a variable appearance, bilateral, you have to raise the red flag in terms of clinical evaluation, systemic evaluation. Would you like to share what the patient had?
Sure, yes. So the patient was a suspected case of attenuated familial adenomatous polyposis. There was a family history of colorectal carcinoma. There was a history of papillary carcinoma thyroid. Patient had underwent thyroidectomy with radiation in 2001, and there was a history of colectomy in November 2012.
So this was basically a classical case of attenuated familial adenomatous polyposis. Now, attenuated and classical is different. Attenuated means they present a little later. She had a colectomy in the second decade of life, whereas if it's typical Gardner syndrome, it happens very early. She also had papillary carcinoma of the thyroid, which is a well-known association. And in this case, we had a positive history. But the message I would like to bring through this case is, when you see this kind of fundus finding, don't think it's innocuous. These patients have to be referred for evaluation by an oncologist or a gastrointestinal specialist. So that's the reason I brought this case. She had all the features that one would have.
So, ma'am, would you also like to elaborate on some similar looking lesion in the fundus and which people should basically watch for, and how do we go about it? So,
Yeah.
like torpedomaculopathy just looks similar to what we just spoke about.
Torpedomaculopathy is usually solitary and just occurs temporal to the macula. There is nothing else. You rarely see more than one. So this is again more easily picked up, but it does not have any systemic connotations. Neither does it have any ocular connotations. Whereas a flat choroidal nevus, like you see here, we do know that nevi can grow, they can turn malignant, they can develop secondary changes. So any pigmented lesion in the fundus should not be ignored. But then again, you need to know what to look for. Like this case was typical. Bear tracks, you can just watch them. There's nothing to be done. Polar bear is the same.
Thank you, ma'am. So, any question, Dr. Chitra, sir?
Right. I think to add on to what Dr. MPB had mentioned, so this is a perfect example of when a clinical observation which is being made. It's we have to understand the language which is trying to convey to us or trying to speak to us. Deciphering this, what it is speaking to us, is so important, and this can, in this particular patient, is uh, especially when we are able to preempt and send the patient for an evaluation to see that the patient would have developed colorectal carcinoma or papillary carcinoma of the thyroid, is so important. So understanding the language with the signs tell us is so important. And in this case which was presented, you'll be able to see how chirpy is different from nevi. So most of the times, like what Dr. MPB mentioned, we look at the polar bear tracts and get carried away with that's the cause of Gardner's or familial adenomatous polyposis, so which is not the case. So the solitary chirpi, the multifocal chirpi, and the typical chirpi where you have the fishtail-like appearance at one of those extensions pointing towards posteriorly are so characteristics of Gardner syndrome. And never to miss even the polar bear tracks or the bear tracks where you can see the smaller footprints are always pointing towards the posteriorly. So with that, I think we'll move on to the last case for this evening's discussion.
Thank you, Dr. Avinash. So the last case, we have a very beautiful case of a 24-year-old female who had come with the complaints of for a routine checkup. Actually, she had no night blindness, and she was 20/20 N6, and this is how her retina looked like. So, Megha, I would like to call you. So when you see a patient like this, what is going on in your mind? How do you go about it?
Yeah, very beautiful picture. First of all, looks like pearls distributed all over the retina. So
Agree.
now, yeah, so it's a fleck retinopathy. Now, most of the fleck retinopathies, they are either associated with night blindness. So the characteristic of night blindness helps us to rule out what kind of fleck retinopathy it is. But now your patient, as you told, does not has any visual deficit, is 20/20 N6, and is not having night blindness. And if I look at the disc and the vessels, so disc appears healthy, the neuroretinal rim appears healthy, as well as the vessels to me looks normal. It does not appears to be attenuation of arterioles, which is seen in fleck retinopathy commonly. Now, if I see the flecks, they are sparing the fovea and the perifoveal and the parafoveal region, and rest of the retina, they are fully distributed till the periphery, right? Now, if I comment upon their size and shape, now size, it is increasing progressively from posterior pole till the periphery, and shape, they are pinpoint round like lesions at the macula, and once they are going towards mid periphery and periphery, the shape is might be like polygonal. And if I tell about the so I spoke about the size, the distribution, that is macular sparing, and then the shape. And there is no attenuation of vessels, there is no visual deficit, and there is no night blindness. So out of all the divergent thinking, what I can think of in a fleck retinopathy, for this case scenario, my top differential will be a benign fleck retina in this case.
Thank you, Megha. So you have very beautifully analyzed this case when you commented on not only the location of the flex, but you commented on the size, and you commented the very obvious things and not so obvious things. So through your analytical, you converged into to the benign. And so with this, I would like to impress upon three clinical pearls. First would be that which are the three must knows in the fleck retinopathy. So you should know what type of night blindness, if at all, your patient has. Then you look into the morphology of the flecks. And third would be that you look at the vessels, if the vessels are attenuated or not. So now we know about that. Moving on to the second pearl, it's about the night blindness, which will help you to diagnose a variant of a fleck retinopathy. So if your patient has a non-progressive night blindness, you'll think of fundus albipunctatus. When your patient has a progressive night blindness, you'll think of retinitis punctata albicans. When there is no night blindness, like for example in this case, you'll think of benign fleck retina. And the another one, a very important one, which I would like to bring to your notice is the fundus xerophthalmicus, where the patients have the reversible night blindness after starting the treatment. The last pearl for the flex is what is the characteristic feature of the fundus albipunctatus. So how Megha was analyzing is just about when you start looking at the size. So the size of the flex increases in the periphery and the center of the macula is spared. So like John Dewey, the modern father of the education, who says that we do not learn from experience, we learn from reflecting on experience. So on that note, I would like to call upon Dr. Srinivas Joshi that what is your way forward in terms of the diagnosis and treatment when you see a case like that?
Thank you, Anamika. You presented a very beautiful case. So first of all, I would like all our postgraduates to know, when do we call it as a fleck retinopathy? It's usually the fundus characteristics by widespread, deep yellowish or white lesions. It might be of various size or configuration or whatever, but it should be without any vascular or optic nerve abnormalities. That is when we usually call them as the fleck retinopathy. So she has, we'll just restrict to only few fleck retinopathies because there are many which are of importance and which have been discussed or showed in the slides now. Originally, we come up with many a times we hear the words fundus flebimaculatus, fundus albipunctatus, familial drusen, familial benign fleck retina of Kandori, or it can be primary hereditary disorders like retinitis punctata albicans, which or a Bites crystalline dystrophy, or any metabolic like Alport, cystinosis. So there are various other causes. So let's go into 4 of these. So coming to the albipunctatus, right? The fundus albipunctatus, usually it is a non-progressive kind of night blindness, which you can see a numerous yellow-white punctate-like lesions. I don't know if you can see here, numerous yellow-white punctate-like lesions can be seen. And it's an autosomal recessive disorders, and lesion is usually at the level of RP when you look into the OCT. So the patient complains of night blindness right from the birth, and a delay in the dark adaptation time after exposure to the bright light. So usually the visual acuity and visual fields in these case of fundus albipunctatus will be normal. The most important investigations what we need to do is fundus autofluorescence, spectral domain OCT, ERG, and molecular testing. In any of these flecks, these are the most 4 important things. So we usually see hyperautofluorescence where there are flecks in case of FAF. SD OCT, you see a hyperreflectivity level at the at the level of RP, which usually corresponds to that. ERG and dark adaptometry, you see the scotopic responses are subnormal, but normalize after extended dark adaptation time. That is one peculiar kind of ERG testing in fundus albipunctatus. In molecular testing, again, it's a definite where we see the mutation in RDH5 gene, because that's the most important. If you see the visual cycle, we have 11-cis retinol getting converted to 11-cis retinal, right? So this catalyst is very important, which is probably missing, and because of that visual cycle, there is a delay in the dark adaptation. Now coming to the next, as she has mentioned, is the retinitis punctata albicans, which is a slightly serious form of disease. It's again a variant of RP with multiple white dots, as you can see here. Rather than pigment deposition, they are more of a white dots here. And again, it's autosomal recessive. Nyctalopia is again a common condition. Peripheral acuity loss and decreased visual acuity is also an important as compared to fundus albipunctatus. Now, it's important to differentiate between early retinitis punctata albicans versus fundus albipunctatus, because in fundus albipunctatus, the prognosis for the daytime vision is slightly better. Whereas in case of retinitis punctata albicans, it's a more severe and progressive because it's a variant of RP. So as Megha very rightly she explained, she looked into whether there are any vascular attenuation. Why? Because she wanted to know and differentiate whether it's a retinitis punctata albicans. She was also looking into the visual field loss, and the most important is more severe electrophysiological phenotype changes we do see in retinitis punctata albicans as compared to fundus. But usually in these cases, they spare the foveal area And later on, they give rise to a pigmentary retinopathy, which is again, as I said, that's why it is called as a variant of RP. Now, coming to another, if we can go on these 4 slides, Anamika, the one she beautifully explained is about the benign flecked retina. So benign flecked retina is again an autosomal recessive with a distinctive retinal patterns. If you see the first slide, it's very beautiful, where there's no apparent visual or electrophysiological defects in case of benign flecked retina. The affected individuals usually are asymptomatic. They have a, if you can see the first slide, there's a striking pattern of diffuse yellow-white, the flecks extending right from the fovea, but sparing the fovea up to the periphery. So again, please remember, FAF reveals hyperautofluorescence of the flecks. SDOCT, which is the second which I was describing, it's a discrete deposit accumulation, which we see at the level of the RPE or at the level of ISOS junction, but without disturbing the ellipsoid zone. That is very important in case of benign flecked retina. MFERG is either normal or mildly subnormal, and since it's a recessive mutation, authors have found out that there is increased low density lipoproteins and total cholesterol count is slightly higher in benign flecked retina. But this should not be confused with flecked retina of Kandori. Another entity where genetic things has not been found out, and they're trying if there is a clinical entity as own. But in this, there will be congenital non-progressive night blindness, irregular flecks, variable in size, distributed in the equatorial region, and these large white region, possibly atrophic, and the night blindness are very typical of the flecked retina of Kandori. So lastly, the fundus xerophthalmia, again, it's because of the chronic vitamin A deficiency, it's a reversible. So because of the fat soluble vitamin, or we call it as a hypovitaminosis vitamin A, limits the growth and weakens the innate and the acquired host differences and leads to more infections. But definitely the dark adoptometry demonstrate elevated rod and cone thresholds, and rods are more severely affected. So the electrophysiology reveals reduced or undetected rod-specific ERGs and reduced amplitude. So, but it is definitely corrected with the vitamin A. So these are the most important things which I think would be of importance to you all. And the other last thing is about the Stargardt's and the fundus plevimaculatus. Again, it's of the both. It's a ABC A4 gene, and I think it's we'll end it now. If there are any questions, we can take it. Yes, Avinash sir.
Yeah, I think Srinivas, you summed it all. What happens is in benign flecked retina and fundus albipunctatus, they look the same. The two important features is one is congenital stationary night blindness, that is fundus albipunctatus, and in benign flecked retina there is no night blindness. So that's basically differentiates these two conditions, which look very similar. And you mentioned about how fundus punctata albicans have attenuation of vessels very similar to that of retinitis pigmentosa, where there's a photoreceptor destruction which causes attenuation of the vessels, and it's a progressive night blindness. Of all these things, the Uemura syndrome is the one where it's very hard to pick up those white dots. So you have to search for them. It's not so obvious. It does not hit at you. So the moment you pick it up, then for you to make a diagnosis of fundus xerophthalmicus becomes a little bit easy, and they disappear also very fast once the vitamin A treatment has been instituted in these patients. So I think that would be a good way in which one can put the first step forward in understanding the flecked retinal disorders, especially those associated with night blindness. I think that's all from our side, Chitra. You're muted.
Yeah. So it's been a truly amazing webinar, which has actually reinstated the fact that ophthalmology is as rich as we enrich it. And on behalf of ARC, our very special thanks to the most respected expert panel, so informed, and the most interesting day for me, in spite of the fact that I'm not a retina surgeon. My very special thanks to these young faculty who did a great job of it, as if they've been doing this for so many years, which is not so. My personal thanks to Dr. Avinash for ensuring that he designed something so very novel and yet relevant approach to teach the postgraduate educative program. and also definitely to the teachers of ophthalmology of our country, those of who have attended it. He truly brought out a difference to this webinar with his very able team. My heartfelt thanks to my ever supportive young ARC team, and Srinivas, you did a great job today. Our thanks to the AIOS admin team headed by Mr. Kripal. My thanks to AIOS webinar in charge, Mr. Sunil. I think you have nearly become an ophthalmologist the way you sit through all our webinars, and significantly you contribute to the smooth running of the webinar. Our thanks to Sai and Manjula at Numerotech, who have been our backbone. Our deep felt thanks to Entode, led by Mr. Nikhil. I think I could never find it enough to say my thanks, because they have been outstandingly supportive for every single ARC venture of ours. And finally, and most importantly, our thanks are due to our dear attendees who have always challenged us to outbeat ourselves to procure the best for them. Thank you, one and all. Thank you so much.
Thank you.
Great webinar.
Thank you, everyone. Thank you.
Dr. Lalit, you went and had your dinner in Kima?
No. I was just roaming around, walked around in the room for some time, that's all. But hearing all through. I heard everybody.
Yeah, very good, no?
Although you see, what I would wish is that, all of you are doing great job. Avinash, great idea. And the ARC team, accepting and going ahead. I did speak to Anamika that, this should be a series of webinars. We are so educative. It should be a series, like maybe we can have series 1 today, you write a series 2, and maybe limit to 5 cases so that, everybody is glued to the chair. Although we were glued to the chair, but I think audience and all, the time should be around, say, around 2 hours or so. So I would suggest Avinash to take it forward and give us a series, maybe 1, 2, 3. Series 1 has been phenomenally successful. Series 2 could be, say, after a gap. I know it requires a lot of hard work, preparation, because myself, Joshi and Anamika had at least 2-3 times meetings also. Extensive background preparation had to be done. So maybe you can, Chitra and Avinash come out with series 2 and 3 also, if you think.
Yes. And I don't think you should share it with